Navjot and Arjun, just check the videos once, please. Thank you.
It gives me immense pleasure. Greetings to all. Greetings to all. It gives me immense second edition of CME on blood safety and quality. Well, the present CME addresses the current practices of blood donor management. We all know
Let's start, guys. Please record. Few minutes to go. Thank you.
As there is a saying, learning is not attained by chance, it must be sought for with ardor and diligence.
आवाज आ रही है?
As there is a saying, learning is not attained by chance, it must be sought for with ardor and diligence. A very good morning and a warm welcome to all the faculties and delegates to the virtual CME on blood safety and quality, current practices of blood donor management organized by Department of Transfusion Medicine, AIIMS, New Delhi, supported by International Society of Blood Transfusion. To update the knowledge on various aspects of advances in this field, the Department of Transfusion Medicine, AIIMS, New Delhi, has been organizing regular CMEs on the theme of blood safety and quality. First chapter of this was conducted in 2019, focused on transfusion transmitted infections and testing. In this series, today's CME is focused on the current practices of blood donor management, and this CME highlights the current aspects of blood donation, ethical and medico-legal issues associated with blood donation, and effect of donor factors on transfusion safety and quality.
Like it is said, without change, there is no innovation, creativity, or incentive for improvement. And those who initiate change will have a better opportunity to manage the change that is inevitable. In this virtual CME, we have tried to involve all the participants by asking them to present the videos on the practices in the donor area that are followed at their centers. Thus, keeping aside the traditional practice of abstract submission, this new way of learning has made the CME unique, innovative, and interactive one. We hope the delegates would benefit from this session. I would like to request our delegates to kindly view and rate these videos on our video rating page, which will be open till 12 noon, and the winner of the same will be declared at the end of the session too. Also, I request all the delegates to mark their attendance in 4 attendance alerts that will pop up at random intervals on your screen. This attendance is important to get 1.5 credit hours that has been given by the Delhi Medical Council to the CME. Also, a feedback form will be available there on your login homepage. Kindly fill the feedback form at the end of the CME to receive your respective certificates. Now I request Dr. D.K. Sharma sir, Medical Superintendent and Head, Department of Transfusion Medicine, AIIMS, New Delhi, to deliver the welcome address. Sir has always encouraged and supported us wholeheartedly in all our endeavors and is our true guide.
Greetings to all. It gives me immense pleasure to welcome you all to the second edition of CME on blood safety and quality. Well, the present CME addresses the current practices of blood donor management. We all know that blood donors are an important key to the transfusion services, without whom it is difficult or rather impossible to run a blood center. Blood donors are the most important link in providing safety and quality blood to the patients, and the CME intends to appraise the participants of advances in the area as well as bring the issues faced by blood centers in day-to-day practice. The idea is to encourage everyone to inculcate the art of evidence-based medicine to the field of transfusion medicine and apply it to their current practices as well. I would also like to welcome the esteemed faculties from the field of transfusion medicine who have accepted our invitation and are participating as chairperson and speakers in this event. I hope that their immense knowledge and vast experience will be useful to the delegates. The Department of Transfusion Medicine AIIMS is also grateful to the International Society of Blood Transfusion for supporting this event in a big way. I would have preferred to welcome you all in person, but because of the current situations, we have to conduct it in virtual format. I hope that the CME will be immensely useful to you all in day-to-day practice of donor management. Thank you all.
Thank you, sir. Without any further delay, we shall proceed to the first session of the day on update on blood donor selection. The delegates can post their questions or comments on the chat box, which will be discussed on the end of the presentations of both the speakers. To chair this session, we are honored to have respected Dr. Neelam Marwa ma'am and Dr. Preeti Elhans ma'am. Both the chairpersons do not need any formal introduction. Their dynamicity and commitment to work has always been a motivation for all of us. Dr. Neelam Marwa ma'am is a former professor and head Department of Transfusion Medicine, PGIMR Chandigarh. She has been the regional director, Southeast Asia International Society of Blood Transfusion. She is currently the chairperson of the National Technique Resource Group on Blood Safety and National Executive Committee on Hemovigilance, and she is a recipient of many national and international accolades and has around 290 publications to her credit.
We are also fortunate to have with us esteemed Dr. Preeti Elhans ma'am, who has made a remarkable contribution in our specialty. Ma'am is the professor, Department of Transfusion Medicine, SGPGIMS Lucknow. She is a recipient of Princess of Wales Award, BBTS. Ma'am is the member of ISBTI, ISTM, AATM, ISBT, and AABB. She has numerous publications in both national and international journals. Now we shall begin our first session by handing over the proceedings to Dr. Neelam ma'am and Dr. Preeti ma'am.
It is my pleasure to introduce Dr. Prasoon Bhattacharya, who will be speaking on understanding the evidence-based selection of blood donors, weakness and opportunities. Dr. Prasoon is professor and head of Department of Immunomatology and Blood Transfusion at Calcutta Medical College Blood Center. He has many years of experience to his credit. He is also an NABH assessor for Blood Center and Transfusion Services. He has established a department at the Calcutta Medical College. He is a resource person in national and state government bodies, expert committee of blood transfusion councils. He is also a subject expert and committee member in CDSCO for blood center related matters, Oncology and Hematology Drugs Division, Government of India. He is also a co-investigator for clinical trials on passive immunization with convalescent plasma and preparation of rare blood donor group registry under ICMR. I welcome Dr. Prasoon for his talk. Dr. Prasoon, please.
Good morning to all of you, and thank you for the organizers for inviting me on this academic CME. So today's topic, I'll be speaking on understanding the evidence-based selection of blood donors, weaknesses and opportunities. So whenever we think of the blood donor selection, the first thing which comes to our mind is the blood donor selection criteria. So its importance is, it is made to safeguard the health of both the donor recipient and the donor, has a high quality evidence for the selection of prospective blood donors. They are evaluated and updated for many medical conditions, especially in relations to high risk behaviors also. They have the clarity and the potential to optimize the blood donor deferral and also enhance the blood safety. So these are the importance, because under any conditions, there should be some balance should remain between the blood donor deferral and also safety of the blood. So it's always a challenge to select the right donors. So for right donor selection, we need a good criteria, as well as we need a well-balanced and well-designed donor health questionnaire. It's a mathematical model. It has shown if randomly donors are taken, the incidence of HIV is 4 times or 4-fold increases on nucleic acid testing. This model is designed on, it is published in 2016 on the Vox Sanguinis. And another important thing is blood donor questionnaire or donor health questionnaire and the donor selection criteria are complementary to each other. And in some cases, they may to some extent, this donor health questionnaire also help in prevention of bloodborne infections or transmissible infections from emerging and re-emerging pathogens. But the actual problem here is art of designing a good donor questionnaire. And we all know the blood and blood components is a licensed drug in majority of the countries. So to assure blood safety, there should be the minimal risk of bloodborne infections or TTIs. And also it's a combination of technical improvement, that is almost, zero risk transfusion is possible due to nucleic acid testing. Also, there should be non-technical pre-screening methods, that is education of the blood donors, non-remuneration concept of voluntary blood donation, and donor health questionnaire, which I have told that donor selection criteria as well as the donor health questionnaire, they are side by side complementary to each other. And depending on the answers or responses of the blood donors on these health questionnaires, their health status, risk behaviors, and possible and probable exposure to bloodborne infections or sexually transmitted infections, they can be assessed. So donor health questionnaire formulation is always a challenge, because it is scientifically designed, but it has to be ethically and legally justified. So science, ethics, and legal justifications. So it should be a mixture and convergence of all of the ideas. So that is the challenge. But the effective donor health questionnaire is the cornerstone of the blood safety. They minimize the donor adverse events, as well as it acts as a safety barrier to reduce bloodborne infections or TTIs. There is a very interesting study to evaluate the quality of blood donor selection. They may be evaluated by monitoring the response and the way of interviewing in the donor health questionnaire, and also versus the analysis of donor deferral rate. So it is published in Frontiers of Medicine on 2018. So we all know blood donor selection process includes 4 main steps. The 4 main steps, they include their pre-donation information, especially related to transmitted infections or bloodborne infections, high risk behaviors, as well as the blood donor adverse events. The next important step is, once the pre-donation information is given, the donor health questionnaire is filled by the blood donor in assistance with the health professionals. Then it is followed by the blood donor interview by the health professional. And last, that is the donor health assessment by the medical professionals in our country. It may be trained professionals in some other countries across the world. So this is if you look at in a nutshell, the donor selection process, you see there are all steps, that is pre-donation information, completion of donor questionnaire filling, donor interview, donor health and risk assessment. There's a provision for self-deferral. So once the donors are accepted, medically fit, again the blood, maybe during blood donations, donor can give the option for confidential unit exclusion, or after donation, if the donor comes reactive or some abnormal results, the donor may be considered for post-donation counseling. And also there are cases where we can assess the temporary and permanent deferral criteria. And if the donor is temporarily deferred, they can be motivated and included in the blood donor pool by their counseling and advice of some medications. So, or after donation, if the evidence-based donors or any selection of blood donor, they involve, that is the most important, there should be appropriate changes in the current donor health questionnaire and the guidelines, and that should be evaluated. There should be clarity in the donor selection to optimize the blood donor deferral. As I have told, selection versus deferral, the criteria should be such, there should be balance to enhance the blood safety. It should not involve any ultra defensive approach. It is very important, because sometimes we may, to assure blood safety, we may become some ultra defensive. As for example, it may be related to the health questionnaire, related to blood pressure of the donors. It may be related to asthma in the donors. It may be related to the thyroid conditions in the donors. So there should not be any, or any other conditions. I am giving some examples. There may be lots of many conditions where we can be ultra defensive approach in preparation of the guidelines, and that will definitely lead to a higher rate of deferral. Address to the possible impact of future blood availability. So it is also important, if the donors, number of donors are highly higher, the deferral rate is, the future blood availability may be questionable. And it should be uniform across the country. I am giving some examples. There may be lots of many conditions where we can be a good donor history questionnaire, donor health questionnaire is formulated, that will definitely, and if it's made uniform, a higher rate of deferral, it will benefit a lot of to the possible impact of future blood, and it will be the most. So it is also important, if the donors number of to assure blood safety, especially in the resource constrained regions. So selecting the right donor and right questionnaire, what are the challenges they come? The questions should be very short and appropriate. They should avoid technical terms and jargons, because ultimately the donor has to comprehend the questions and give the proper response. There should be avoidance of double-barreled questions. Double-barrel means a single answer to many of the issues. The question should not be set like that. The issues should be defined specifically, and any measurement or assessment should be done donors on the basis of the ordinal scales, that is quantitative measurement of the donors, where the donor can give quantitative examination. Because if I say, suppose for example, do you have any history of fever in the last month? So sometimes the donor might say, well, there may be fever, there may not be fever. Then if we ask of the severity of the scale of fever, then we can get some response here, it was severe. But if I properly ask whether what is the temperature recorded during that time, that should be in the ordinal scale. Otherwise, the questions comes in the nominal scales. They should not be. They should be avoided. So, and also avoidance of complex sentences in formulating the donor health questionnaire. And on the other hand, the donor's perspective, they should properly interpret the donor health questionnaire. They should not, their memory should not be taxed. Suppose if a donor has donated blood 4 years ago, if I ask at which date you have donated the blood, it will be very difficult to retrieve from the memory by the donor. So questionnaire should be designed in such a way that should not be taxing in the memory of the donor also. There should be balance of judgment and non-judgment, because it is a very subtle way. Because if I say, suppose for example, if I speak to the donor, if we see the persons having multiple partners are having high risk behavior, so here there may be chances, especially in sexual risk behavior, donor may give some his judgmental opinion. Although he or she might have number of partners, but at that time they may be judgmental, they may hide this response, proper response. So that is very important here. So it should be a balance of judgment and sometimes non-judgmental issues should come in the response. And also response editing. So the donors, it is very important, especially where computerized donor response is recorded. So here the donor have the option to edit the response. Now, another part, because why evidence-based donor selection is included, because that is the blood current quality assurance in blood transfusion service. It is approaches from vein to vein, that is from the donor to the transfusion the recipient, and identification of the right donor is always a very critical input in this quality assurance of transfusion services. And another most important part of this is intention to donate blood is the key motivation to practice blood donation. So the questionnaires, guidelines, whatever we decide, first of all, we have to assess in the population the intention to donate. It depends on demographic distribution. It depends on the knowledge status or education of the blood donor pool. It depends on the cultural behavior and socioeconomic practice. So it is worthwhile to study the intention of a group of population for blood donation and come up with evidence-based interventions. It is important because until and we assess the population's motive, we cannot design the guideline. Until and unless we design the proper guidelines, we cannot get the adequate number of safe donors. There is a very important analysis in this paper, that is reasons for blood donation among the donors. You see, individual initiative which plays a great role. Then comes organization initiative, that is initiative from the organization, that may be their societies, their local organization, or they may be the organized blood transfusion services. So it is very important. There should be individual initiative on the donor's part to donate blood. Then everything, the donor selection criteria, donor health questionnaires, quality assurance comes. And on parallelly, if we see the reasons for not donating blood among the donors, that is lack of knowledge, fear and anxiety, lack of interest, and lack of opportunity. So they form a major cause where the donor doesn't donate blood. So the criteria should be evidence-based, questionnaires should be rightly designed so that we can educate the donor properly, we can counsel the donor and helps in the participation to make the voluntary blood donation successful. Another part which is now recently becoming a very important concept in the research, that is association between donor characteristics, blood quality, and patient outcome. There are quite a number of studies which show that in vitro quality of stored red blood cell products or platelet concentrates may be affected by some of the donor characteristics. So a proper selection blood donor based on evidence-based criteria, it is needed to minimize donor-associated risk for poor product quality. So this is again, if I consider the process input, you see donor selection criteria or the blood donors who get selected, so they form a major important part in the blood to maintain the quality of blood and blood components. Other variables are there like time limit for blood processing, environmental control, component specification, storage temperature, but the most important is the blood donor and its blood donor selection criteria. That is the right donor. So going through the research, another important thing came, that is due to hemovigilance, that we get to know the right gender for plasma donation, because the gender of the donor may influence the type of blood component prepared from the donation. That is, plasma-rich components from multiparous women are more likely to cross trally and related disorders than those from the males. So because the plasma from these donors, they contain antibodies which against human leukocyte antigens or human neutrophilic antigens which are transferred passively during the transfusion. Another important thing is related to hemolysis or related to the hemolysis. There is an inherent enzymopathies in the donors or red cell membrane defects. So it has been observed individuals with G6PD or other inherited red cell membrane defects without history of hemolysis, a history may be acceptable, but how their blood is not suitable for intrauterine transfusion, neonatal exchange transfusion, or patients with G6PD deficiency. There is again another important study showing proteomic analysis of red blood cells from the donors. They exhibit a high hemolysis and demonstrates a reduction in membrane-associated proteins involved in the oxidative response. So we know, all of us, we know already that the red cell storage lesion is a multifaceted biological phenomenon. So genetic, undiagnosed, or subclinical medical conditions and lifestyle factors, they may affect the RBC characteristics, their lifespan, energy metabolism, and sensitivity to oxidative stress. So nowadays, the donor-related studies are much more looking at the proteomic analysis of the red blood cell membranes. This is a very, this is the picture which showing the RBC membrane disorders, hereditary. We all know we do not screen routinely among the donors. We only screen the hemoglobin level, but they play an important role in the quality, in the stored, in quality of the blood component, and some of the patient outcome. So an increased understanding of these variables can be used to improve the quality of blood components for transfusion. And also we may use some donor management algorithms based on donors' individual and molecular and genetic profile in the future. So assuring high quality of blood components, it is always challenging because variable nature of biological raw materials, which a blood is collected from a donor, there may be different due to technological improvement. There is different manufacturing processes. They are coming different methods of platelet preparation, platelet storage, platelet preservation, red cell preservations. They are coming. There may be pathogen reduction technology. It will be in the near future, in futuristic approach. So they are coming. So different manufacturing process. So the donor characteristics becomes very important. Variation in quality testing methods, and some of the products even are subjected to some non-traditional manufacturing or storage. As I have told that they may be pathogen inactivated, they may be irradiated. So they are non-traditional manufacturing processes. So that they have to the RBCs or the particular component has to sustain those variations. So current good manufacturing practice ensures the blood operators to maintain safety, quality, identity, potential, purity of the blood components. So this is a picture which showing the understanding the relationship between blood donor variability and blood component quality. So here you can see the donor factors, that is, we do not routinely screen in the donors, but they may be important in the coming days. That is genetic abnormalities, enzyme deficiencies, red cell membrane defects, platelet receptors related, platelet responsives. Regarding the donors' lifestyle like smoking, alcohol, BMI, lipemia, medications, and interdonation interval, which may play a very important role in the coming days. Production factors like different processes of filtration, leukofiltration, platelet productions, anticoagulant plasticizers, post-production that which have already and storage, they also play a role. So ultimately, the evidence-based guidelines and rationally designed donor questionnaires, donor health questionnaire also becomes important in this issue. And last but not the least, the advent of very precision medicine, which seeks tailored to the healthcare delivery. So we all know now that is, medicine is evidence-based medicine, and to achieve maximum benefit based on an understanding of the factors that contribute to health and disease of an individual and population. So medicine is now becoming individualized. And also, maybe at that point of time, the donor quality, donor characteristics are become very important to in the patient's treatment and its outcomes. There are interesting studies, I think, also in the CME also we have some separate topic which is taken by quality donor characteristics influencing the quality of the blood components. So the interplay between the donor characteristics, blood product preparation, storage and patient characteristics on the outcome of a transfusion is always multifactorial, and there is a very interesting study published in Blood Journal on September 2019. So this study, the effect of donor component and recipient characteristics on hemoglobin increments following red blood cell transfusion is noticed. Here we see very interesting observation. It is done on 23,100. It is a retrospective audit, of course. It is done on 23,194 transfusion recipients who received one or more single unit RBC transfusions from the period, their 8 to 9 years period, 2008 to 2016 in Northern California. Here we have seen, they have shown that blood donor influences the response. That is, male blood donors having age less than 70 years, Rh positive donors blood, they have shown to increase the hemoglobin rise in the transfusion recipient. Again, the method of preparation, that is apheresis blood collection, gamma irradiation, and storage of blood more than 35 days, the transfusion of post-transfusion hemoglobin increment is less. And on the recipient factor, again, female recipients, Rh positive recipients with lower body mass index, low hemoglobin level, the percentage, the hemoglobin increment is increased. So these are the factors. So the future points towards that there should be individualized donors, there should be evidence-based donor selection criteria which addresses to the donor requirement according to the customized need of the patient. So understanding evidence-based selection of blood donor, it involves appropriate donor selection guidelines followed by the right donor health questionnaire, and it should rationalize the donor impact deferral and the impact of donor deferral. That is very important. We cannot lose the donor availability by creating very stringent criteria. So we have to focus on that. They should rationalize the deferral and the impact of donor deferral. They should address to blood donors and recipient safety. They are an essential part of quality assurance in blood transfusion service. And last, to conclude, I should say, increased understanding the variables can be used to improve the quality of blood components for transfusion by using donor management algorithms based on donors' individual molecular and genetic profile. So they are the futuristic approach, or rather the approach is ongoing now and very ongoing. And these are very important things, that evidence-based selection of blood donor is a very important part in the blood transfusion service, and which will be of a major area of interest in the coming days. I thank you again, and thank you all for all the viewers. Thank you.
Thank you very much, Prasann, for that excellent presentation. And I think there would be question answers after both the speakers have completed their presentation. So now I have pleasure in inviting Dr. Suchet Sachdev. He's presently Associate Professor, Transfusion Medicine at PGI Chandigarh. And he has done his MD from BJ Medical College, Mumbai University. His area of expertise and experience is 15 years and primarily in the field of voluntary blood donation and transfusion transmissible infectious disease testing. He's also associate editor of Indian Journal of Hematology and Blood Transfusion. And he has had a patent granted on innovation in blood donation process to reduce vasovagal reactions. He's recipient of Dr. Usha Gupta Award of the ISBTI 2019, and he's vice chairman, ATOM India chapter, and he has 40 publications. And he would be giving a presentation on deferral from blood donation, positive and negative impacts on blood donor. So Dr. Suchet Sachdev, please come forward with your presentation.
A very good morning. I am Dr. Sachdev from the Department of Transfusion Medicine, PGI Chandigarh, and I have been asked by the organizers to speak on deferral from blood donation, the positive and negative impacts on the blood donor. So this is the institute from where I am, and it is an institute of national importance and one of the earliest places where seeds of voluntary blood donation were sown in India by our founding head of the department, Professor Jai Gopal Jolly at Chandigarh. So I have to thank the organizers, and there is nothing to disclose except that the entire presentation is based on either published articles, and they have all been duly acknowledged in the references. So this is a snapshot of the state-wise availability of blood units, and you can see that the country has been divided into different colors. Red are the states which are deficit in availability of blood, yellow ones are adequate, and the green ones are surplus. This may not reflect the absolute picture because at times you have a big institute like the one I am from in a relatively small city, which is a union territory like Chandigarh, and it has an institute of national importance, and it caters to patients from majority of the adjoining states. So this is from the same SNACO report. Similarly, the proportion of voluntary blood donation. You can see the ones colored red have less than 50% voluntary blood donation, and similarly are the other colors, and the ones shaded green are having greater than 75% voluntary blood donation. Now, when I was offered this talk, I was wondering why I was given such a talk. So the background is that the amount of blood collected could be increased in two ways, either by encouraging new donors to start donating or by encouraging the existing donors to donate more often. Or you may have both these strategies. Now, the challenge for blood collection agencies is to devise strategies that encourage non-donors to make their first donation and to devise further strategies to reduce donor dropout and to motivate behavior change that will lead to a committed regular donations. Establishing a reliable method of predicting who is most likely to donate blood would improve the likelihood of such strategies succeeding. However, accurately predicting who is most likely to donate blood remains problematic, and further research in this direction is needed. Then let's talk about donor research. So traditionally, research on blood donation behavior has taken either of the three directions. The first direction has been to compare the demographic characteristics and personality traits of donors with respect to non-donors. Second research direction has been towards the reasons that motivate in those who give blood and the factors that deter in those who do not give blood. Third research direction has been towards understanding of the effect of donor experience on long-term donation behavior. And significantly, the third research direction has considered what motivates a first-time donor to develop donation habit, leading to them becoming regular committed donors. So I'll be covering this small journey in certain headings, and they will come detailed on each slide. So now deferral, I was asked to talk on deferral. So I could see we had a simile. So a postponement of an action or an event. So the organizers of the present event decided for a deferral from January to March in view of COVID. Now there could be to delay something until a later time, like my bank has agreed to defer the repayment of my loan. Can we defer making such a decision till next week? And synonyms, postpone, similarly, simply put, you can order furniture now and defer the payment until March. So normally this slide is put that we get a smile. So moment your EMIs are postponed, you get a smile. Normally deferral would elicit a relaxation feeling or a smile. Now, what is different in deferral with respect to blood donations? Now, donor deferral means that individuals is not eligible to donate blood based on the criteria used to protect the health and safety of both the donor as well as the transfusion recipient. And individuals disqualified from donating blood are known as deferred donors, though in person, I believe the word disqualified is slightly harsh. It should be individuals who are requested to withhold from donating blood are known as deferred donors. A prospective donor may be deferred at any point of contact during the donation process, collection, and or testing. The deferral may further be temporary, that is for a specified time period only, or permanent, that would be that no time limits apply. Now these are the deferrals which are as per the Drug and Cosmetics Act, which was notified in 2020 in the month of March. So as you see, we can have medical conditions like low hemoglobin or cardiovascular conditions, high or low blood pressure or a different pulse rate, medication intake, certain deferrals for females specific like menstruation, pregnancy, abortion or lactation, vaccination, the COVID vaccine deferral engrossed all of us, and then deferral for infectious markers like COVID infection, malaria, typhoid, and other diseases, respiratory or endocrine deferrals, minor non-specific symptoms, allergy, a GI upset, a performance of an endoscopy, migraine, a past blood transfusion, then donation not due, previous blood donation not within the specified limits as per the local regulation, and in a change or dose of a medication for a lifestyle disease. Surgical like major or minor surgeries, tooth extraction, age, weight, and miscellaneous like tattoo, ear piercing, lack of sleep, fasting, alcohol intake, apprehensive donors, and foreign nationals. Now, how does it impact? So to impact on a situation, process, or person means it affects them, and a marked effect or influence. Now, what is a negative impact? A fact, situation, or experience that is negative is unpleasant, depressing, or harmful. And a positive impact is a fact, situation, or experience that is positive, is pleasant, motivating, reinforcing, increases confidence, or is beneficial, giving cause of hope. Now, what are the unique features of deferral for blood donors? Blood donor deferral is done with a positive intent. However, it may have a negative impact on the donor and ultimately negatively impact not only a repeat blood donation on the individual donor, but also donations from his or her peers within their network influence due to negative advocacy against the donation process or the donation cause of donation itself. The deferral might benefit the donor in some cases when a silent underlying medical condition is identified through early screening process, resulting in early institution of treatment for the prevention of long-term morbidity or mortality and the cost and financial implications prevented thereof. So deferral rate and the variables it may vary between the type of donations and across the different settings. I mean the deferral site. More for whole blood donations as compared to plasmapheresis donations. Variation in the number and type of deferrals may be due to several variables like differences in the risk profile of the local donor demography, donor ethnicity, and the variation in donor selection legislation criteria, subjectivity in the application of the deferral processes by the persons involved in that process. Deferral rate and other variables, the a higher deferral has been noted in female donors, young donors, first-time donors, and replacement donors. The subjectivity in delivering a deferral does impact the donors' perspectives toward the blood transfusion services and may lead to confusion or frustration and ultimately may diminish the confidence of the donors in the blood transfusion services. So deferral at the site of donation could be at the blood center, at the outdoor voluntary blood donation drive, or in the modern state-of-art blood mobiles, which are blood donation centers incorporated in a heavy-duty vehicle. Or deferral may be prior to presentation at the site of donation. Some countries have a tele or online appointment system wherein the donors may be pre-screened and result in a deferral. So this was a nice study which I could find, the blood donor deferral analysis in relation to the screening process, a single center study from southern India with emphasis on high hemoglobin deferral. So their retrospective analysis of deferral record for whole blood donations was done, and it was performed with respect to the categories or stage 1. So stage 1 was deferral during evaluation of donor history questionnaire. Stage 2 was deferral during medical examination. Stage 3 was deferral during hemoglobin check. And stage 4 was before phlebotomy. So this is well depicted in this diagram. So you could have a deferral pre-donation information to the donors during enrollment, at the evaluation of donor history questionnaire, medical examination, hemoglobin check before phlebotomy, during phlebotomy, and there could be as we will come later, confidential unit exclusion and other special circumstances. And the majority they found what the highest deferral was in stage 3 based on hemoglobin, which is apparent in our country because of the low hemoglobin noted. So insights on donor deferral reasons promote proactive measures toward donor recruitment and retention, and hemoglobin screening would be more appropriate using a quantitative method. Now, what about the deferral site? Deferral after blood donation, this is usually done based on test results like transfusion transmissible infections results, based on red cell serology, rare group donors, donors having irregular antibodies or those having a positive DAT, those having HLA antibodies in plasma, those who have given history of confidential unit exclusion, or probably what we have seen is the divergence of history of an attempt to be contacted by blood center after the last donation with respect to some unresolved tests, either TTI or RBC serology, before or after donation as per the timeline of the interaction of the donor with the transfusion services. So donor surveys a few days after temporary deferral have found that only a minority recalled feeling high level of negative emotions at the time of deferral. So donors in general are happy-go-lucky and they may tend to not feel that high emotions, or the emotions may wane over a period of time. Lower negative emotions among those deferred during a pre-donation telephonic screening support the importance of identifying ineligible donors before they present to donate in person. So this is more so specific to the present era, wherein we had to go through a COVID pandemic where there were restrictions to travel, and such strategies may help the blood transfusion services channelize or optimize their transfusion services. Among on-site deferrals, the higher levels of anger and lower feelings of calm were associated with a lower intention to donate again. In turn, since only a minority of deferred donors report high level of negative emotions, there may be scope of a relationship with the dialogue between the staff and donor to be an important factor influencing the donor psychology and the consequent willingness to donate again. Higher deferral in females may partly be explained by iron deficiency in the childbearing age group, since this pattern changes in comparison with males as the age advances. However, females may be deferred for many other reasons and not just for low iron related hemoglobin, as was explained earlier. Female whole blood donors have been shown to be 11 times more likely to be deferred as per the results from a study by Mast et al. A higher deferral in young donors is also decreased steadily with increasing age. Further, the effect of age with respect of being deferred varies with gender and the deferral type. For example, the deferral of a low hemoglobin may increase in male gender, but may decrease with age after menopause in females, in line with the statement above. Deferral more in first-time donors in general, except that in repeat donors, the deferral for low iron-related low hemoglobin may increase in high-intensity donors. Generally, the repeat donors have gone through the donor selection cycle and thus may be less likely to be deferred for non-hemoglobin deferrals. For donation status and demography. In first-time donors, males were less likely to return, whereas in repeat donors, males were more likely to return. Studies have shown that African, Asian, and Hispanic donors may be at a higher risk of deferral compared to the white donors. And lower donor return rates following a deferral are seen in donors born outside the United States of America and non-white donors, younger donors, though the effect on gender is at times conflicting. A number of factors are known to influence retention of blood donors, like previous donation patterns, negative experiences at previous donation, including reactions, convenience of donations, psychological construct of the donor, including attitude, intentions, norms, and anticipated regret, demographic characteristics such as age and the level of education. So what are the donor emotions? So this is a visual depiction of time course of emotion as conceptualized in the TED approach. So before the first donation, there is an anticipatory emotion, there is an immediate emotion, reflective emotion after the first donation, and anticipatory emotion. Subsequent donation, there is a similar immediate emotion during the subsequent donation, and then there is a reflective emotion, and then the interaction between all that leads to an anticipatory emotion. So these are the emotions of top 5 emotions generated by donors with corresponding percentage of donors at the time. So in the waiting area, 17% donors were happy, around 13% were nervous, 9% seemed calm, 8% seemed relaxed, and 6% were excited. And in the prenatal phase, you see the nervous starts going up. So there were 13% nervous in waiting area, which has increased to 17% nervous. And during donation, the happy is again back to 15%. And in the refreshment area, people are predominantly happy. They are relieved that they have done a wonderful job. They feel relaxed or satiated. They feel good and satisfied. Now, the effect of deferral on the donor. So there are studies, Whitaker et al. Has reported strong negative emotions like fear, anger, feeling of stigmatization and rejection among permanently deferred donors in Canada. Delage et al. Reported that the feeling of moderate distress experienced by donors upon notification about false positive screening tests fell to low levels after about 1 month. It means remains, which is understood that the donors have reconciled with the deferral over time. And the intensity of a donor's negative emotional reaction to being deferred varies with the nature of the deferral, temporary versus permanent, and the implications of the reason of the deferral on the donor's health. So this was an article which says that donors can experience 3 types of negative events during or after donation that deter them from donating again. The first is the application of a deferral, which occurs when a donor is assessed as ineligible to donate. The second is the negative event that occurs during or post donation and takes the form of a perceived or during a vasovagal reaction. The last type of negative effect is a service failure where the donor's expectations with regard to the donation experience are not met. So emotions experienced when receiving a temporary deferral, perspectives from the staff as well as from the donor. So they have said that the staff reported that donors frequently had negative emotional responses to being deferred, particularly anger, frustration, and rejection. And then they did certain exploratory analysis and they concluded that emotional reactions to receiving a deferral impact the donor's intention to redonate, particularly among those deferred in center. And blood collection staff may be able to address donors' emotional responses to help diminish the impact of being deferred on donors' intention to return. So when asked why some donors do not return at the end of deferral period, many staff felt non-return may be attributed to donors' emotional response to their deferral. Staff reported that some donors appear to feel rejected and they are unable to give blood. So these people are giving gift and they still want to give a gift and we are saying no, they cannot. So that's the emotion behind it. And they have even said disgruntled word is being used. Another main theme that arose from the staff interview was that one staff member described a donor with a long donation career as devastated after being deferred for 6 months. She's been donating since she was about 18 and she's like 74 time donors or something. And so she was quite upset with the deferral. Another was that the hard thing is when they wait for a few minutes and then they come through and you tell them that you cannot donate. It's a long waiting times. And that is the time when they tend to get annoyed. So this was another, the emotions reported by blood collection staff, the call center agents and the medical officers. So the blood collection staff reported anger, anxiety, confusion, happy, rejection, and sadness. It was mentioned in at least one interview with staff member of that particular group. Call center agents said anger, anxiety, confusion, rejection, and sadness. Medical officers also reported, except for anxiety, all the other feelings. So this was the feeling of the donors with respect to being deferred. And these are the main differences between such comparisons. So you will see that deferred via pre-donation phone call or deferred at center, there are differences in the anger factor, anxiety factor, calm factor, and these may be exploited for making strategies, suitable strategies for enhancing donors. Why does a deferral have an effect on subsequent donor behavior? It is well understood that deferrals negatively impact donors' subsequent donation, but there is limited knowledge on why it occurs. Particularly the donors who report unsatisfactory explanation for the deferral are less likely to return to donate. Only a minority of donors recall the feeling of high intensity negative emotions when surveyed a few days after being temporarily deferred. So the emotions also wane just like our antibodies wane in multi-transfused. The donor's perspectives remain crucial but less worked on. And these are the various reasons. It is disruption of a habit. It is confusion with regard to eligibility. It is concerned about being deferred again. Feeling off the hook, donor may feel rejected, disappointed, annoyed, their time being wasted, alteration in the perception of being healthy or being capable, negative interaction with blood staff, inadequate or unsatisfactory explanation given. So the specific nature of deferral also appears to be of importance in the impact on subsequent donation. Donors is found to return more quickly to donate following a deferral for low hemoglobin in comparison to deferral for a tattoo or a piercing. Overall, there was a weaker impact of donor return in deferrals enacted for protecting the health of donors in comparison to deferrals enacted for protecting the health of the recipient. This is very important because generally the factors which are for recipient are of the type which you do not want those donors in your donor pool normally. However, the ones deferral is for the health of the donor can be overcome and the donor may come back into the pool. Deferrals and subsequent donor behavior. So Pilyavin et al. Reported a poor return in first-time donors who were deferred in comparison to those who were not deferred, 2.8 versus 27.3. In that study, the difference was not noted in repeat donors. Alperin reported a lower return donation rate in deferred donors as compared to matched control arm, 62% versus 80%. And the non-deferred donors donated 80% more whole blood units over the next 4.5 or years of the study period. Therefore, deferral is expected to have an enduring impact on donor psychology and donation return behavior. Bednall et al. In a meta-analysis with sample size of nearly 5 lakhs reported a negative relation likelihood of subsequent donation following a deferral with confidence intervals not crossing 1. So it was a significant less likelihood of coming back. So the likelihood is only 37% of coming back post a deferral. They also reported that experienced donors were less likely to be deferred from subsequent donation by a temporary deferral. Similarly, Brohen et al. Used regression discontinuity design with sample size of nearly 80,000 donors, reporting that female donors are almost 14% points less likely to make at least one donation attempt within the next 18 months after any repeat hemoglobin deferral, and males are only 5% point less likely on a similar note. Custer et al. Reported in around 7,500 donors who were longitudinally followed over 5 years after deferral in a blood center at US and observed a small impact in repeat donors on donor return post-deferral in deferred versus non-deferred group. So the deferred were 81%, non-deferred repeat donations were 86 in repeat donors, but a larger impact in similar impact in first-time donors, 25 vis-a-vis 47%. And the first-time donors may take a longer time to return. Hillgrove used a multivariable logistic regression model in around 70,000 donors in Australia and reported a donor return rate of close to 60% in deferred donors and close to 90% in non-deferred controls. So those deferred were significantly less likely to return in all 3 years follow-up with an odds of 13 versus 30 versus 31. Speckman et al. In a retrospective Cox proportional hazard model on close to 350,000 donors in Netherlands reported in experienced donors 96% non-deferral return versus 92% in deferred donors. They also reported that first-time and reactivated deferred donors were less likely to return to donate when compared with similar deferred donors. Shah et al. Reported a 2.8% return in first-time donors vis-a-vis a 36% return in experienced donors. repeat donors in a study following deferred donors in Ahmedabad from Gujarat in India. So it has also been shown that rapid return donation in new donor is positively associated with the long-term commitment to donation. In first-time donors, the reasons may be that they have no prior experience of donating successfully and develop experience of donation and the competence of being able to donate in order to experience a positive benefit of donation, and have not developed the warm glow of being a repeat donor or the sense of identity of being a blood donor, which may help mitigate the negative experience of being deferred. And similarly, in first-time deferrals, the reasons may be that strong donor identity deferred for a low hemoglobin appeared more likely to return to donate. And first-time donors are more likely to mistake a temporary deferral as a permanent one, and are also more likely to overestimate that they would be deferred at the subsequent donation attempt. They may also have less positive view on the interaction with the staff at blood center because they are new, and that is the perception they will likely carry. So this is another nice paper which says the negative experiences and pre-donation blood pressure at the subsequent donation. So they found that whole blood donations with negative previous experiences were associated with a statistically significant higher pre-donation blood pressure at subsequent visit, and then this indicates that negative experience might cause an anticipatory stress reaction in subsequent donation, just like the white collar hypertension we all now mitigating the impact of deferral on donors. So developmental of communication strategies to facilitate calmness among donors during the deferral conversation and clear information for donors about the nature of the deferral, their eligibility, and then when would they be able to return for donation, or to minimize the feeling of dejection in temporarily deferred donors with using the time-tested approach of information, education, and communication, keeping in touch with the temporarily deferred donors in between the deferral period, the donor engagement, targeted recruitment efforts after deferral has expired. So a callback ideally as soon as possible after the eligibility is regained, or to work on modalities to re-recruit temporary deferral donors. That is the communication and motivation. The short-term strategies could be easing the deferral process. The preliminary step in the reinduction of temporary deferred donors starts at the time of the deferral. Inclusion of options for a self-deferral using online donation scheduling may help in reducing the time spent in physically reaching the donation center and the waiting, as we had earlier seen. Proper documentation of temporary deferred donor record, without which such donors may be lost to follow-up from the blood center's records. Communication, this is the most important step which helps in donor return. Some donors misinterpret their deferral to be permanent or assume that they will be rejected in their next attempt as well, as we previously saw. Hence, information on the nature, reason, and duration must be clearly, yes, politely conveyed to the donor. Fixing the next appointment for donation and guiding the donor towards an alternate good deed can also be a motivating factor. Enrollment in research studies or timely reminders like SMS, email, telecon can also be done. And long-term strategies are easing the donation process, improving donor awareness, and involving donors in donor welfare clinics. Setting up of such clinics could be a step towards hassle-free way of helping donors obtain investigation and treatment for simple temporary deferrals, reasons like low hemoglobin. And Clement et al. Found better return donation in donors given a designed new appointment card compared to a simple thank you card. So 71% return in first 4 months of becoming eligible versus 53%. So there was almost a 20% increase with the designed new appointment card. And the alternative good deed option, Masser et al. Have reported that deferral from whole blood donation did not demotivate them for conversion to plasma donations, as these keep them engaged with the donation and help sustain the self-identity of a blood donor and may actually facilitate a later return to whole blood donation as well. So interventions could be mails, telephone calls, SMS. Shah et al. Reported that calling the donors back after completion of the deferral period demonstrated a 31% donor return at a large blood center in Gujarat, India. Walls et al. Reported that telecon soon after deferral with a request to either schedule an appointment or agree to receive a follow-up call at the end of deferral may also be very effective. And then this was a very nice study, intentions condition plan. So Godin et al. Reported an almost 20% greater chance in the next 4 years after the first lifetime donation by implementation of this intentions condition plan to overcome the 3 common barriers to blood donation: forgetting to attend, fitting the opportunity to give blood in one schedule, we are busy all the time, organizing transportation to the donation venue. And this 20% was greater chance was with respect to the mere measurement in the people who did not form such plans. And the results of this study indicate that implementation intentions could be a useful strategy promoting donor return among temporarily deferred novice blood donors. And the donor's psychological reaction to deferral following false positive screening tests, informing donors of possibility of re-entry appears to contribute to maintaining a positive predisposition towards future blood donation. It does not, however, appear to alleviate the distress felt after being notified of a false positive infectious disease marker result, nor does it increase willingness to give blood again in the future. Now, the positive impacts of a deferral could be that we deferred donors for COVID infection and we motivated them when we deferred them for convalescent plasma donation. Counseling and raised awareness on the risk factors or acquisition of TTIs during the post-test notification. Knowledge on the need of self-exclusion from offering to volunteer for blood donation in the event of diseases that may be provoked by phlebotomy and result in a transient ischemic attack or a cardiac event or status epilepticus or status asthmaticus, detection of high blood pressure, detection of low hemoglobin or low iron, vitamin B12 and folic acid deficiencies. We had such donors with low hemoglobins and they responded to vitamin B12 and have now started donating platelets because they feel attached with the blood services. Detection of asymptomatic infections, it is ultimately a positive impact because it leads to early treatment institution. There are tangible positive benefits to the family in case of counseling about TTIs. There is a decreased spread to the family as close contacts, and counseling and raised awareness of blood groups, rare groups, subgroups, irregular antibodies, and the need to have corresponding antigen negative future blood transfusion. So you may offer special IH cards to such donors when they require any transfusion. Conversion towards platelet donation. So this was one direct result of the donor post-test notification. So where we concluded that the present role of the blood transfusion services in TTI testing, donor notification and counseling and referral can actually be compared to a miniature public health model. The screening of asymptomatic donors serves as a mode of secondary prevention in terms of finding undiagnosed infections. The referral for further confirmation and management serves as a mode of tertiary prevention in form of intervention to reduce disease burden and extensive information education about modes of acquiring these infections as part of donor talks, motivation, recruitment on mass public scale serves as a mode of primary prevention by raising awareness and reducing the risks. And the follow-up of such data was that among 167 donors, 30% were put on medication and 35% were on follow-up. So close to 65% of the donors which we referred were on follow-up. Some provided medicines, some not medicines, but on follow-up because they have based the medicine schedule on certain viral testing, viral load copies, and they keep the testing, the institution of treatment in abeyance till you have a higher viral load. And this was that large number of blood donors have hypertension based on the updated 2017 hypertension guidelines. So they concluded that significant percentage of hypertension among blood donor indicates a need and an opportunity for blood donation centers to improve donor health through blood pressure screening and education on hypertension. Similar endeavors can be put forth towards diabetes and certain other lifestyle diseases. These are the references, and thank you for a very patient listening.
Yeah. Yes. Thank you, Dr. Suchet, for that, I think, very elaborate presentation. And in the chat box, I saw just, I think there was one question on that sickle cell issue. The 1-year-old was negative before transfusion, became positive for sickling after transfusion. So would Dr. Prasoon like to take it up? I think Dr. Mukhopadhyay has already given part of the answer, but Dr. Prasoon, would you like to explain it a little further?
Good morning, all of you. Thank you, ma'am. So the question was interesting that infant was previously sickle negative and now he came to be sickle positive post-transfusion. Well, there are two aspects. Before deciding the transfusion, I am sure that definitely this patient was been adequately investigated for the condition where transfusion was given. And regarding routinely, we do not do the sickling tests, but transfuse cells itself. I don't know what is the storage time of the cells also. Maybe there may be some false positivity comes because it's a little, it's a new, almost infant, and the volume of transfusion, if we compare the respective transfused cells, so that might come. So donor may be called up for checking the sickles is a very good is a very very primary, shall be a very primary practice in this case. Otherwise, thorough investigations may be done, but as we know, there are storage lesions. They also sometimes, although microcytes are much more commoner, we do not seldom see that sickle cells. I don't know, maybe there may be chance of false positivity also in these cases.
But I think even the baby needs to be reinvestigated, maybe
yes.
3 months after transfusion.
Transfusion.
And one should go in for the family history of that infant who had received the transfusion. So whenever we come across issues of genetic problems, family history, family investigation. So I think both from the donor and the patient side, we will need to have a relook. So I think that should give an answer to this question. So I did not see any other question in the chat box, and I think we can take the proceedings further, and we would like to express our sincere thanks to Dr. Prasoon Bhattacharya for giving a very balanced account of, looking at the rigorous donor selection criteria, but at the same time, we have to also balance it with the sufficiency of blood supply. So recipient health, donor health, and sufficiency of blood supply. So you must keep these three principles in mind whenever there is any further modification of donor health questionnaires in our country, because already we have updated these guidelines at least in 2017. And if you look at the WHO guidelines, these were there in 2012, not yet updated, although there was a talk of updating, maybe 5 to 7 years, that is the usual time, but maybe COVID has delayed a lot of things. And again, as and when new infections come up, we go on adding them in our selection process. So as the evidences generate, and I would also like to thank Dr. Suchet. I think, Preeti, I can do it on your behalf so that you can take it further for the next part of the session. Thank you very much. And yes, we all know that deferral has a very negative impact. And as you have shown, there's a lot of emotional issues to it. So Prasun, balancing science, safety, we also have to look at the emotional aspects of the donor. So we must have a holistic view, and it is good that in this particular CME, we have brought out issues related to donor selection as well as deferral, which is a very important part. And
I think blood centers need to have deferred donor clinics as well.
Very good. That's an excellent suggestion. Yes. Yeah. So thank you once again, Prasan and Suchit. So I would request Dr. Preeti to take the proceedings of the session forward now.
I thank the organizers and the speakers. And I think we would be next year having a debate. So over to organizers.
Yeah, so we can introduce the yes, Gopal, are you taking over?
Yes, ma'am, I can take over from here.
All right. Yes. Thank you.
Thank you. Thank you. So thank you, speakers and chairpersons of the first session for knowledgeable session. So now we move forward about our next part of the session, in which we discuss about the post-donation information. Post-donation information is kind of the new concept in our country. So our two esteemed faculty of the country, Dr. Abhishek and Dr. Dheeraj, will give their point of view about this post-donation information. Dr. Abhishek is the additional professor in Kidwai Institute of Oncology, Bangalore, currently in Jipmer, Pondicherry. His specialization in MD Transfusion Medicine and DNB, MANS, AABB certificate course in the cellular therapy. He has a notable honor achievement and awards like ISBT Young Scientist Award, ISBT Harold Johnson Fellowship Award in 2021, ISBTI HD Shore Award in 2022. He also has National Academy of Medical Science Scientist Exchange Program Award 2021. Our next panelist is Dr. Dheeraj Khetan. Sir is also additional professor in SDPGI Lucknow. He was formerly assistant professor in the PGI MER Chandigarh and consultant blood safety state AIDS Control Society UP. His MD Transfusion Medicine and SR from SDPGI. He also awarded by the Harold Johnson Fellowship in ISBT 2006 and Young Scientist Award in Indian Society of Transfusion Medicine in 2014. He has 35 publications in Indus Journal, Associate Editor for Asian Journal of Transfusion Science, and External Examiner for various MD and PhD examinations. So let's start our debate on the post-donation information. So first, I would like to start with Dr. Dheeraj, sir. Sir, can you please tell us about what's the meaning of the post-donation information?
Yeah, I hope I am audible.
Yes, sir, you are audible.
Okay, thank you, Dr. Gopal, for your nice words. And I would take this opportunity to thank the organizers, Dr. Haim and Dr. Gopal, for giving me this opportunity. And I also wish to pay my regards to the two chairpersons, Neelam Marwa ma'am and Dr. Preeti Allens. It is my proud privilege to be sharing the dais in a sense with both of them. Now coming to the topic, what is post-donation information? It is a relatively new concept which has come up in India, but it was there in, I think, USA since last 30 years. And it refers to any information which is provided by the donors following a donation. And this information is such that it would have led to a deferral of the donor had this information been known at the time of selection of that particular donor in the selection process. And for me, it is an extension to the concept of confidential unit exclusion. As we all must be aware, this was a concept which was applied earlier. And where it used to happen that the donor informed about the risk or possible risk of having some infection in the donated unit, and we used to remove that unit from the inventory. Another way of understanding, maybe it may be thought as a reverse of a donor notification. In donor notification, it is the blood center which is informing the donor about possible risk to his health or abnormal test result. But in this post-donation information, the donor informs about such possibility to the blood center, and after thorough analysis of this information, the blood center may decide to take some action in the form of quarantine or recall of that particular blood component, or if it has been transfused, it may be look back, and there may be requirement for notifying the recipient. So this in a nutshell is what we understand by the post-donation information.
Yeah, thank you, sir. So, Dr. Abhishek, what are the other donor data or donation data can be included as a post-donation information, and what could be the intended use of that, if you can say?
Okay, so thank you, Dheeraj sir, for briefly explaining what is PDA. But there is also an extension to this PDA that, am I audible?
Yes, yes.
Yeah, thank you, sir. So not only it has expanded to that sense that it's not only the information that could have led to the deferral, it could also include the information. For example, somebody developing some minor symptoms after donation also has been included in post-donation information as of now. So classically, this post-donation information is divided into early and late. So the early ones is usually defined as the ones till the next further donation. From this donation till any time before the next donation, whatever information that the donor gives you, or it could be given by a third party, or even sometimes by a government agency or something about the donor or the donation that has been done. So all this is usually included as the early PDI, and the late PDI is something that is received at a subsequent donation itself or after several donations. So now, especially as sir was telling about the look back or something, when subsequently the donation becomes positive, you get a new information about why this could have been done and what were the previous donations that this guy has made. Classically, we go up to 1 year before the last negative result as to see what all donation. So the information with regard to all these, that is the high risk factors and other things that could have the donor had, which he did not reveal as a part of the screening process, the new infectious diseases that he acquired or came in contact with after donation, or any diagnosis of infections like hepatitis or HIV within the 12 months after donation. And also the persons that he met or have been in contact with the travel history that he has undertaken, surgical procedures, or any other invasive procedures that could have been led to the risk, the diagnostic procedures that he has undergone in the past, which he failed to inform, either because it could be intentional withholding of the information due to various causes, or it could be an information that he did not know and which he came to know only after that, either due to a new test or a new symptom that he developed later. Including all the medical reasons, the non-sexual risk as well as the non-sexual infectious risk like tattoo, piercing, and other things, probably which he did not know, whereas or due to the probably the system of screening, the questionnaires did not include that information, or it was not understood clearly by the person who answered those, or the hazardous occupations, dietary habits sometimes that the donor follow. All these things can be included in the post-donation information. And now what do we do with that information? We all know that false negative test results are always possible in the early stages of infection, what we call as the window period, or the donor health questionnaire, which probably has failed to capture this information, could be this can be, the information can help us to reform them, redo them, and include the information or make it understandable in a better way by the donor. And if you want to do some kind of blood component recall, if at all this information has led to, is given you an information that could have been detrimental, we can trace back those units to whoever it is given, and if something can be done, treatable causes can be still benefited from this PDA information. A performing of a prompt medical evaluation later on the donor who has given you this PDA, further risk assessment related to the affected donations or the quality and safety of the blood components that has been collected, or the things that could help in continuing the safety of the donor himself, and also the time, the effect of the time elapsed from the potential risk and the donation, probably the sensitivity of the test that failed to actually pick it up or something like that. This could all be revised. There could be a possibility of performing an additional test on the available units, or include it as in a prospective manner. Obtain other medical records from the donors from elsewhere, or like especially when we send it for fractionation units of units and all that, or inclusion of something like a pathogen reduction, or the storage time to release, or the quarantine of the units. All this can be revisited with the help of this post-donation information.
Yeah, thank you. One more thing, can we include any rare group antigen which we find during the immunohematological testing of the blood donor sample? That also we can include in post-donation information?
It can be included in the donor database, so that if the donor comes in future, he can be, for example, it happens very commonly in our camps. For example, Bombay, we collected as a O in a camp, and later we came to know that it is a Bombay unit. So then, yes, we can update that in the our database, and also update the donor and inform him, so that in future he does not unnecessarily, without requirement, donates in camps or elsewhere. So that can be done.
Okay, thank you. So what's the best approach to store this data? Can we store it locally, or we have to store it at a central basis? So is it available to all?
So logically speaking, the easiest or the first thing to do would be to start as a local, because the implications are less. It's very easy to get information, as well as the permissions required with regard to storing it locally and using for the blood center which has collected the same. But though it is very feasible to do, but a more meaningful and useful one would be to share across the centers, because with the exodus and the movement of donors, it's possible that the donor who donated here could go and donate in a different center. So I would say that with regard to feasibility, yes, it's very easy to start it as a locally, but to make it a meaningful and a useful one, it has to be shared across centers in a big way.
Yeah, thank you. So, sir, Dr. Dheeraj sir, can you say what are the possible potential challenges or disadvantage to storing this data by independent government agency or transfusion society?
Yeah. Before proceeding further, I would like to make it clear that although this is pitched as a debate, it is not necessarily, it should not necessarily be seen as a debate. It is more of a discussion, because it is not that I am speaking against or Dr. Abhishek is speaking for the implementation of PDI in India. And like coming to your question again, Dr. Gopal, for storage of the data at the central or local level, what I understand that it hardly matters if the data is stored at a local or central level. It is more important to understand is who manages the data or who takes any action, who controls the data. That is the important question to ask, I think. And if we take a clue from other countries where this program is implemented, and all the countries, it is being done under regulatory requirements or to comply with certain guidelines or standards. And it is not being done solely by an individual blood centers. And even if it is being done by an individual blood center, the data needs to be shared with the central agencies. And that is how it is coordinated and the information flows. Now, taking an example, if the data is stored solely at the local level and not shared with the central agencies, then it may lead to improper or non-uniform practices across different blood centers, as happens for any other activity in country like ours. And if the information is solely at the central level, it may be a problem in assessing the assessment of the post-donation information. For example, if there is a donor who comes and informs that he had some high-risk behavior for last 5-7 years, and he has donated 5 to 7 times during this period. Now he discloses that he has that sort of behavior, putting them at risk and the unit at risk, although the unit has never come reactive. The units need to be discarded because the donor would have been deferred otherwise to fulfill the requirements. Now, the data about his previous donations will be available only with the local blood center. They will not be available with the central agencies. And therefore, a close coordination with the central agencies and the local blood centers is essential in implementing this practice. Now, with regard to if a government agency or a private agency should look into this implementation, all these across globe, like in the USA, it is being done by FDA, and in Canada, it is being monitored by Canadian Blood Services, who report to Canada Health, and in France and Greece, it is being done under the hemovigilance program of that respective countries. And nowhere this post-donation information is being managed by a transfusion society per se. In my opinion, transfusion societies have a role in development of these guidelines or policies, and not in the data management or running of the routine activities of a blood center. And societies actually do not have any regulatory or supervisory authority on the activities of the individual blood centers. And therefore, it is difficult for the societies to monitor these activities. Yes, they can frame the guidelines, but the central role should be with the government agency, with the regulatory or some obligatory requirements where the blood centers have some obligatory requirements to fulfill.
Yeah, sir, but either data can be stored locally or centrally, but according to our country or in view of our country, what could be the possible legal implication to share the data with others?
I think the problems are lesser in our country. It is more so with the to do with the education status of the general population. The more the people are aware, the more legal or lawsuits you are going to face. Because this is a sensitive donor information, and disclosure for a blood center may lead to breach interest with the donor and his willingness to donate again in future. We may lose the donor, and the donor may actually file a defamation lawsuit if the information is somehow made public, or people are aware of why the donor was deferred, or what is the information that he has shared. The donor may file a lawsuit against blood center if the information is shared with another blood center. For example, if the donor has shared some confidential information with my center, and he or she goes to donate again at any other center across the country, and if I share the information without the permission of the donor, we may it is a confidential and information, and strict confidentiality of any personal information about the donors and their test results should be ensured at all times. This is the legal or regulatory requirements, and a breach of confidentiality may therefore negatively affect this bond and trust. And the medical data we can share only with other healthcare providers who are directly or indirectly involved in the subsequent care of the donor. If the donor is getting benefit by sharing the data, then we can share. Otherwise, it calls for it may be under a scrutiny, and we can face some legal actions. And the donor may also claim monetary damages from the blood center. If the donor is unnecessarily harassed, or he has to travel, undergo certain tests, and the blood center may be held responsible for the entirety of these losses, and in addition to any punitive charges that may be levied on account of defamation. And therefore, we have to be careful in dealing with this information. That's what I think.
Okay, thanks, sir. So, Dr. Abhishek, you can say what kind of the data we can share. It's can be limited type of data, or all data can we share with others?
Yeah. So coming to the post-donation information that we saw, there are lots of data that can be included in post-donation information. But what could be shared should always be the one which is relevant, which can what we call as a practice-changing data. For example, say some donor has revealed something which could lead him to permanent deferral. So maybe for research purposes, it may be useful as to what led to that permanent deferral. But what the other blood centers or the agencies need to know is that just he can't be accepted as a donor. They need not know the details as to why not. So there should be a filter kind of thing which assesses this post-donation information and gives a what you call as a flagger or a decisive kind of thing that yes, this donor cannot donate for next 2 years or next 12 months, or he can never donate. So that information alone is necessary for the blood agencies. Ultimately, they have to decide whether this donation can. So for the other purposes, the data can be handled locally for the upliftment or the betterment of the donor or the safety of the donor concerned. And these need not be shared unless for some academic or research purposes.
Okay, thank you. So, sir, what's the positive impact or positive purpose to share this data which can impact positively on the public or populations?
Yeah, apart from being useful in improving the transfusion safety and the donor safety issues, addressing the donor safety issues, this post-donation information can be of use, as you have already mentioned, that it can be useful in maintaining and managing the information in the form of a rare donor registry, and the permanent deferral donor data, which may be, if it is centralized, it may help in streamlining the activities across different blood centers of the country. An important aspect which has been recently looked into is the research potential in terms of diagnosis or investigation about emerging infections. Like, for instance, if there is a donor who has some fever, which is unspecified, not specific, no, it is not a specific complaint, and upon further investigation, you come across some new virus which has caused the symptoms in that particular donor. And this has been investigated quite a lot in recent COVID times. That the donors and we have all witnessed these things, and there are publications available that the donors were accepted before, and then the blood was discarded because at that time there were no clear guidelines regarding the deferral for COVID infection. And as Dr. Abhishek also has mentioned that it can be also useful for research purposes and better designing of the donor information material, donor health or history questionnaire, and this may improve the transfusion safety. And again, it is again useful for safeguarding the blood centers also. If there is some transfusion reaction and then we come to know after the transfusion is done, and the donor later on informs about some possible associated risk factor, and therefore we can explain if there is any legal requirement that the reaction was not due to a fault at the or error at the blood center level, but because of the this risk behavior that the donor had. So these are the possible uses, I think, which are useful if we implement this post-donation information system.
Yeah. Thank you, sir. One question from the participant also regarding our next question is, how can we prevent the security or privacy of this stored data?
I think it is, we are already doing such things. We are already into such practices. Like the direct donor identifier should not be stored with or the information regarding the identity of the donor. These should be linked to a unique ID. And in countries where this is implemented, it is now linked to the social security numbers or the Aadhaar card number, for instance, in our country. And the donor logs in through using that social security number, and he or she can confidentially log into the donation information and change that information. As Dr. Suchet was also sharing in his presentation, that is quite possible nowadays. And this confidentiality can be ensured through use of unique identifiers and use of codes for infectious markers. Instead of writing down as HCV, HIV, or HBV, we can use codes so that the information, when it is shared, it is not of much use to anybody who is not aware about the codes. And in particular, anonymity between the blood donor and the recipient. That traceability information should not be there. If the person who is transfused gets some sort of problem or issue, and later on he comes to know that the blood was transfused from this particular donor having this problem, which was informed as post-donation information, then this can be a complication. And therefore, by coding, we can get across these things. And these things, I think, we are actually following routinely for all other information which is stored in the blood center.
Yeah, thank you. And Dr. Abhishek, as Dr. Neelam ma'am mentioned that the donor consent would be needed to share the donor specific information beyond the local blood centers. So yes, I think it should be need the donor consent before sharing the data. Thank you. And sir, Dr. Dheeraj sir, can we tell what could be the future perspective of post-donation information management in our country?
Okay, frankly, for me, it is actually a hypothetical concept. There is lack of evidence that about the usefulness of this post-donation information system in improving the blood safety. It mostly is directed towards infectious risk prevention, and most of the time the units are already issued when the information is received at the transfusion center. In a study in Europe, it was shown that approximately 77% of the PDI was received when all the units were already issued and transfused to the recipients. And it requires a detailed data collection analysis, and which requires increased manpower and which can be utilized in our setup for improving the donor selection process itself, which is lacking, and much more still remains to achieve for improving the transfusion safety and voluntary blood donation in our country. Now, for implementation, as Madam has also pointed out, and there is no pre-donation information being shared with the blood donors currently across most of the blood centers in our country. And this is a prerequisite for implementing this post-donation information program. Now, nevertheless, this PDI can be seen as an activity which can help us further enhance the transfusion safety, and it should be, in my opinion, added as another dimension to the under the hemovigilance program of our country, because it has ramifications both in the donor safety and the patient safety arm, and guidelines may be formulated in near future. As I see it, there may be kiosks which similar to the airports where we go and the donor can use the kiosk or log in through some internet facility using an app in the mobile, undertake the self-assessment and get himself herself registered and book a slot, and then donate, and using the same information the donor can again re-log in to provide information about this post-donation information system for implementation of the system. And this should raise an alarm at the local blood center, and upon the assessment of the severity, as Dr. Abhishek was sharing, it may be decided to share the information with the hemovigilance program of the country, or it may be managed at the local level if any action is not required to be taken. And this is how I feel in near future it should be incorporated in the hemovigilance program of our country.
Thank you, sir. Thank you so much. Thank you, Dr. Abhishek and sir, for providing knowledge about the post-donation information, which is kind of near to our country. And thank you so much.
Thank you. Thanks a lot.
So, any other questions from the participants? So, Chairperson, also if you have any kind of the question or comments on the present session.
Well, I think this was really a good session, and both the speakers or the experts have come out with very good suggestions, and considering that our country, people are becoming more and more informed, and we have a lot of information technology, we have a lot of apps, and we are improving our internet connection. But still, till blood banks are computerized and there is good data management, we cannot even implement it through the hemovigilance program as Dheeraj suggested. I agree that once something comes in the ambit of a government program, it is easier in our country. Because if it is done by an independent group of professionals, it becomes very difficult. But still, we really need to see that all our blood centers are computerized, and there's a lot of IEC campaign for the donor base, just as when we were doing it for the HIV. So the awareness has increased. Similarly, when you're talking about post-donation information, you must classify it as to what are the kinds of information, what is it, which the donor might want. It should be kept confidential. It's a question of blood group. I don't think there is going to be any problem. But yes, when it's a question of TTIs or something else, people would like to have more confidentiality. And in the previous session, I think Dr. Preeti's remarks on donor welfare clinics and on Suchet's last slide. So, we have to go on devising ways and means of raising awareness, creating that infrastructure which is required, and then deciding, and then we'll have to also modify our consent in the donor questionnaire. As and when we have introduced anything new, whether it is sending plasma for fractionation, whether it is sending blood to blood storage centers, we have included it in the donor consent form. So similarly, this also should get included once we think of implementation. But I think the idea is excellent. Your thoughts on this are excellent. And you could actually make a concept note and send it to the hemovigilance program, and let's see what is the reaction. I would also like to get inputs from Dr. Preeti. Yes.
Thank you, ma'am. Very rightly said. We need to think among ourselves, like what is the information that we want the donor to provide. We should be very clear on that, how this information will be received by the blood center and how we are going to process and then get back to the donor. Do we need to get back to the donor, or like any authorities, do we have to report? So meanwhile, before implementing, we can do this kind of brainstorming sessions among ourselves, the experts, so that this program can come into being.
Yes, you can have a group of volunteers work on this, and why not Dr. Dheeraj, Dr. Abhishek, Dr. Gopal? I mean, we do need young experts. I mean, Dheeraj was so kind enough to say that he's sharing the dice with us, but we are happy to share the dice with you, because it's always good to see the future torch bearers of the profession in our country. So
thank you, ma'am, for your kind words and encouragement. And taking a cue from your suggestion and what Madam Preeti has said, I think all three of us will definitely sit down and make a rough draft or some proposal, and we will surely send it to the hemovigilance program for consideration and further detailed deliberations and discussions in this regard. We'll draft something. We all three, I think, will do that.
Yes, I think it'll be a good idea, and you could also take guidance from Dr. Preeti. And
yes.
yes. So yes, thank you. It's been very nice, Gopal, Dheeraj, Abhishek, and nice to see Dr. Preeti also. Thank you so much.
Thank you, ma'am. Thank you so much for giving us time and providing this guidance.
My pleasure.
And,
thank you.
Thanks to all chairpersons and speakers. Thank you so much.
Thank you. Thanks a lot.
Thank you very much.
Thank you all for this informative session. Now, without any further delay, we shall begin with our second session of the day, which will be focused on donation effect on blood donor and recipient. Delegates can post their questions or comments on the chat box, which will be discussed on the end of the presentations of both the speakers. To chair this session, we are honored to have respected Dr. Debashish Gupta sir and Dr. Ravneet Kaur ma'am. Dr. Debashish sir is currently the professor and head Sri Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum, Kerala. He is an executive member of various technical bodies and founder president of Federation of Blood Donors of India. Sir has worked as a program director, blood safety with the USAID, and as principal investigator, blood safety with CDC Kenya for 3 years. He is a recipient of several national and state awards.
We are also privileged to have Dr. Ravneet Kaur ma'am today with us. Ma'am is professor and head Department of Transfusion Medicine, Government Medical College and Hospital, Chandigarh. She is the member of Core Committee of Hemovigilance Program of India and National Academy of Medical Sciences. Ma'am has been the editor of Asian Journal of Transfusion Sciences and has many awards to her credit, including J.R. Jolly Award for her vital contribution in the field of transfusion medicine. Now we shall begin our second session by handing over the proceedings to Dr. Debashish sir and to Dr. Ravneet ma'am.
Thank you. I cannot see Dr. Debashish. Is he there? Am I audible?
Yes, ma'am, you are audible.
Dr. Debashish sir is there? Anyway, should I start the session then?
Yes, ma'am, you.
Okay. So first of all, I'd like to thank Dr. Gopal and Dr. Haim for giving me this opportunity, and also like to congratulate them to have a CME on such an important theme. I mean, the first session was excellent, and I think many important things came out of that session, and I think the second session is also going to be the fruitful one. So without wasting time, I would like to invite the first speaker. Our first speaker is Dr. Asim Tiwari. He's Director, Department of Transfusion Medicine at Medanta Hospital, Gurgaon. He has over 85 publications in national and international journals. He is recipient of H.D. Shure Award and also a recipient of J.R. Jolly Award. He's a reviewer to several journals which are of national and international repute. And he is also currently Joint Secretary of ISTM. And I would like to invite Dr. Tiwari to deliver a talk on delayed impact of whole blood and apheresis donation on health of blood donors. Dr. Asim Tiwari, over to you. Yes, Dr. Tiwari, we can see your screen. Kindly continue.
Good morning.
Morning, we can hear
My
you.
topic is delayed impact of whole blood and apheresis donation on health of blood donor. At the very outset, I would like to thank AIIMS team, especially Dr. Gopal Patidar, for inviting me for this talk. I would also like to acknowledge my colleagues, Dr. Geet and Dr. Shammi, who have helped me put together this presentation. The outline of this talk is that we are going to very briefly talk about the beneficial effects of blood donation. We are going to then emphasize on delayed adverse effects. And the delayed adverse effects have been classified into short-term delayed adverse effects and long-term delayed adverse effects. And we'll also keep talking about the mitigation strategies, how we need to prevent, how we need to mitigate these adverse effects so that the donors feel confident and they keep coming back as repeat donors and regular donors. So there are certain beneficial effects, especially in the Western literature. So for example, this is one very important study which people quote very often. Donation of blood is associated with reduced risk of myocardial infarction. This has been done by an ischemic heart disease risk factor study. And this study claims that blood donors had 88% reduced risk of acute myocardial infarction compared with non-blood donors. One of the mechanisms by which this risk was reduced was by reducing the iron by frequent blood donations. But in a country like India, where there is already the iron stores are not very good in the population overall, this data may not really apply to us. So this has to be kept in mind, but we must be aware that there is a certain study which has been done in the other part of the country, other part of the world, and but that data may not really apply to us. We should understand that donors are, comparatively a healthier subset of the general population. And this happens because, number one, they select themselves. So, whenever there's a family, to younger and healthier people come forward for donation. And moreover, there's a donor selection process by which the health personnel ensure that the healthier donors are selected. And there is a very interesting fact called healthy donor effect, because donor on donation feel good about themselves. And this also has a role to play in the overall health situation. And this is important to understand because the next paper which we are quoting is that blood donation and blood donor mortality after adjustment for healthy donor effect. They did it in over 11 lakh donors, of whom 15,000 died during 95 lakh 26,627 person years of follow-up. So there was a long follow-up. And after additional adjustment for internal healthy donor effect, each additional annual blood donation was associated with a reduced mortality risk of 7.5%, which is substantial. However, again, there is a disclaimer that this is not a conclusive evidence, and this cannot be taken as a gospel truth for all the donors. But this does give an opportunity for people to do more research and find out whether it applies to other populations as well. So after having understood certain beneficial effects of reduced mortality and reduced myocardial infarction, we'll come to actually the adverse donor effects, which is more important for today's in today's context. We are aware that blood donation is considerably safe procedure, but a very small number of donation may experience adverse reactions, referred to as ADEs in this presentation. Literature, however, commonly describes and reports immediate adverse donor reaction. So there is a lot of literature on immediate adverse donor reaction, IAR. However, donor can experience and does experience a delayed adverse reaction, DAR, after the leaving blood center or maybe much later. And this delayed adverse reaction present a very unique challenge for identification, because many a times these are not even identified or reported. There's a very passive way. So we tell the donor that if you have a adverse reaction, please report to the blood center. But we are not sure. We don't follow up every donor, so we're not sure as to whether it is the correct number and which we are able to identify. Their management and any prevention or mitigation strategy that is there. And of course, the blood transfusion services, BTS, has a responsibility to prevent and mitigate DAR, because any adverse reaction would put off the donor, and the likelihood of donor coming back for blood donation goes down. Whether it is an immediate adverse reaction or a delayed adverse reaction, the concept remains the same, that any adverse reaction is decreases the likelihood of donor coming back to the blood transfusion services. So we need to ensure that we keep them to the minimum and we mitigate to whatever extent it's possible. Now, the adverse donor reactions have been are the complications related to blood donation and events with a temporal relation to blood donation, and they can be either immediate or they can be delayed. Immediate is reactions are those which occur before, during, or after blood donation within the blood center premises or blood bank premises. The delayed short term can occur within days to weeks, even after the donor has left the premises and has gone back to his workplace or his residence. And there are also long-term delayed adverse reaction, which sometimes takes months and years, and they're more common in repeat regular donors. So therefore, they have been classified as delayed short-term and delayed long-term. In the delayed short term, they are again either localized or systematic. The systemic, the localized ones are bruise, hematomas, delayed breathing, sore arms, allergic reactions, paresthesia, allergic. Systemic ones are vasovagal reactions, fatigue, weakness. And long-term delayed adverse reactions are a possibility of calcium depletion with donors who do very frequent apheresis procedure. Protein depletion or immunoglobulin depletion in donors who do frequent plasma donation. And disturbed iron balance or anemia in repeat regular donors. So we're going to talk about each one of them one after the other. We'll take up the short terms first and the long terms later. If we talk of short-term donor adverse reactions, there is a bruise, which is a bluish discoloration of the skin due to accumulation of blood in the tissue outside the vessel. And the blood from damaged blood cells keep, go beneath the skin, collect under the skin, and they result in discoloration, and sometimes also, there is a swelling and discoloration both. The symptoms are discoloration, swelling, and local pain. Sometimes there can be a delayed bleeding or rebleeding, and this is leakage of blood from venipuncture site after the initial bleeding had stopped. And this may be related to pressure not being applied to the correct location or for an adequate duration, or sometimes premature removal of the bandage. After the donor has left the clinic, the rebleeding may be related to heavy lifting or strain. So that could be another reason that, though they are advised not to do gym or do any heavy lifting after blood donation, but sometimes donors ignore that and do something of that sort, and that can also cause delayed bleeding. The spontaneous recommencement of bleeding from the venipuncture site is the symptom and signs. Nerve injury is very uncommon, thankfully. The nerve may be hit directly, which is even more uncommon, but sometimes there may be pressure on the nerve due to hematoma or inflammation of the soft tissue. And this causes a radiating sharp pain moving away from the venipuncture site, and or paresthesia such as tingling, burning sensation in the hand, wrist, shoulder area away from the venipuncture site. So this is the classical presentation of the nerve injury or irritation. And they generally seek medical advice in such adverse reactions. Sometimes donor have a complaint of painful arm or a sore arm. So the pain is the primary symptom without characteristic of a nerve irritation or a presence of a large hematoma or a bruise. The pain may be related to tissue injury, possibly due to hematoma in the deeper tissue, which is not visible from the outside. And they may be accompanied by bruising, discoloration, swelling, and local pain, or pain without any other symptoms is also possible. Localized infection and inflammation may occur along the course of vein, which is thrombophlebitis, or in the other soft tissue, other than the vein, which can be a cellulitis, and generally donor would seek medical attention in such cases. Vasovegal reactions, which are more common in the immediate adverse donor reaction category, but can also happen in the delayed adverse reaction, and there's generally an autonomic nervous system which causes that, and usually, it is discomfort, weakness, anxiety, lightheadedness, dizziness, nausea, chills, sweating, vomiting, pallor, hyperventilation, rapid or slow pulse, or a combination of few of them. The most difficult part is that sometimes it causes loss of consciousness and can result in an injury because donor has left the premises. They may be in the lobby, or they may be outside the blood center premises, and sometimes you have to rush to that area to look after the donor and to take him and provide the medical care to such donors. Allergic reactions can happen because of the disinfectants such as iodine. This is one classical picture which shows allergy to an adhesive bandage, and they can occur in hours or days post-donation, and also has a potential of causing itching and redness. This is one study which was done at our center. Post-donation telephonic interview of blood donors providing an insight into delayed adverse reactions. This study was conducted to estimate incidence and profile of donor adverse reactions through telephonic interview. Donors were contacted 3 weeks post-donation. Over 1,000 donors were contacted. And the commonest adverse reactions that were reported were bruise, hematoma, delayed bleeding, painful arms, allergy, vasovagal reaction, and fatigue. And another very important thing which was concluded in this study was that donor delayed adverse reactions are actually more common than the acute immediate adverse reactions, but they are not reported. So reporting is much, much less unless you have a proactive mechanism of finding out the way it was done in this particular study. We also looked at other studies. So Newman is the one who has done a lot of work on adverse reactions from US. There is a study from Greece. There is our study. There is a study from Dr. Desai in Mumbai. There's a study from Dr. Gupta in Delhi, and there's a study from Kaur et al. From Chandigarh. And they have all been done between 2003 to 2021. And most of them have taken whole blood, but one study has also taken single donor platelets. The sample size varies from 500 to 1,000. But what I want is your attention to the risk factors. The risk factors are common across the studies. So most of the studies say that women have more commonly the delayed adverse reactions. The first-time donors has been reported in several studies. The younger donors, for example, this study says age less than 30 is another risk factor. Low weight, like for example, this study says that weight lower than 60 and BMI less than 18.5. So these are the common risk factors. And if we are aware of these risk factors, so we know that the common findings across all these studies are that these adverse reactions, the delayed adverse reactions are common in women donors, common in first-time donors, common in younger donors, common in donors with lower weight and BMI. And therefore, we can pay special attention to these groups, who are particularly vulnerable to delayed adverse reactions. Educating donors is again one important aspects of mitigating the reactions or the response to the reaction. So if the person knows, expects that there is something which can happen, for example, a hematoma or a bruise, they adapt to it better as compared to one who are not educated. Post-donation instructions are given by almost every blood center. There are different ways. Somebody would give a pamphlet, somebody would display those instructions, or both. What we have recently done is that what we have started giving these instructions in their as a SMS. Every donor, when they complete the donation, they get a SMS, and in the SMS there is a link, and the post-donation instructions are provided. So even from a legal point of view, we ensure that every donor has received post-donation instructions. Well-trained staff is again a very important aspect to mitigate these things, that they can allay their anxiety, allay their fear, and counsel them and refer them to the physician if so required. So once we have understood the short-term delayed adverse reactions, we'll come to the long-term donor delayed adverse reactions. One of the adverse reactions which is suspected is that during apheresis donation, ACD, anticoagulant ACD, is infused to the donor, and it complexes with calcium, and this complex is excreted. But it increases serum parathyroid hormone, and there was a suspicion that serum parathyroid hormone may lead to resorption of calcium from the bone. This is shown better in this diagram. So whenever their ionized calcium level goes down, it sort of triggers the parathyroid hormone, the PTH, parathyroid gland, the PTH goes up, and there are three mechanisms. It increases the absorption from the small intestine, it increases the reabsorption from the kidney, and it also causes the resorption from the bone, and therefore there's a risk that the bones may become weaker. Though half-life of citrate is only 36 minutes, donors are able to fully metabolize exogenous citrate from apheresis collection within 24 hours of exposure. But G protein coupled receptor on the receptor of parathyroid gland and kidneys directly sense decline in the ionized calcium concentration, and there's a theoretical possibility that the bones may get resorbed. Now, this is the study which, would take care of all such apprehension. Impact of frequent apheresis blood donation on bone density, a prospective, longitudinal, randomized controlled trial. So the very, very high, level of evidence. They took male volunteer blood donors between 18 and 65 years of age. Those who agreed for 20 or more than 20 apheresis donation in 1 year. So they're all high repeat donors who were recruited for this study. And if you look at the box and whiskers plot, the control and apheresis, is not really, very different. This is the change in bone marrow density, and this is the control apheresis in the lumbar spine, in the hip also, control and apheresis. And there is, no marked difference between the control group and the apheresis group. And this is what has been reiterated here also, that total hip BMD did not change for control donors or apheresis donors. The trabecular bone score was measured, and this again did not change in the donor of the apheresis arm. And therefore, the correct collection guidelines adequately protect the skeletal health of adult male high-frequency apheresis blood donors. This risk is even lower in our country because we don't really have donors who donate 20 times in a year. Usually the number is much fewer, so the risk is further reduced in our setting. And of course, internationally, there has to be an interval of 48 hours between two apheresis donation, and the apheresis donation cannot be done more than 2 times a week or 24 times in a year. We should also understand that procedural settings can be done to control the amount of citrate which is introduced to whole blood in the extracorporeal circuit. And there are various ways of doing it. So the inlet pump rate the speed can be reduced. The anticoagulant flow rate can be reduced, or the whole blood anticoagulation ratio can be changed, especially after the initial half an hour. And we do all these things very commonly, especially in a therapeutic apheresis setting, to ensure that lowest amount of anticoagulant goes into the donor or into the patient. Another theoretical risk is that donors who do plasmapheresis donations very often may have reduction in their immunoglobulin levels, and their immunity levels may go down. Though generally it is believed that plasmapheresis donors with normal immunoglobulin production would never have a blunted immune response. But there is this very interesting study done by Norda et al. They studied immune responsiveness in plasma donors, hepatitis, who were also receiving hepatitis B vaccination. And they found that there was no difference in T half-life of antibody response. There was no correlation with the donation frequency, total volume of plasma donated, or peak antibody titer. This was one of the posters in ISBT 218, courtesy Dr. Shammi. Even in India, the Gazette notification issued in 2020 is very clear that the serum protein shall be 6 grams per deciliter before the first plasmapheresis procedure. During the COVID crisis, there were a lot of COVID plasma donations, and we ensured that the serum proteins were done even before the first procedure, and they have to be 6 grams per deciliter. They were 6 grams per deciliter before donor was put onto the machine. In the repeat plasmapheresis procedure, the guidelines say that regulations say that the donor has to be tested before the third procedure if done within 4 weeks, and it again has to be more than 6 grams per deciliter. And the quantity of plasma that can be separated from the blood of the donor shall not exceed 500 ml per sitting once in a fortnight, and shall not exceed 1000 ml per minute. So there are regulatory safeguards available even in our country to ensure that there is no depletion of plasma proteins or immunoglobulins in a repeat plasmapheresis donor. So both these reduction of bone marrow density as a result of apheresis, or reduction of immunoglobulins as a result of plasmapheresis, actually are not, possible in a donor with the current regulatory guidelines that are there. However, this long-term problem which we have with donors is actually very important. We need to understand that this is common, especially common in our setting. Iron deficiency is the most widespread nutrient deficiency causing anemia in all age groups, irrespective of gender, caste, or religion. The serum ferritin values were less than 15 microgram per liter was observed in 30.5% of donors. This is one study. Another study from Chandigarh, where they recruited 400 voluntary blood donors, serum ferritin levels were lower than 15 in 41% of 21 and 46% of male and female donors. So female were almost twice as many. Who donated once every year, 29 and 27% in men and women who donated twice per year, and 49 and 100% who donated 3 times every year. So look at the data that almost half the men and all the women were having low ferritin values if they donated more than 3 times or more than 3 times in a year. So very, very big, burden of this disease in regular donors. We also need to understand that it's not that anemia may be, visible or maybe very apparent. There are several stages of iron deficiency. On the one end of the spectrum, we have a normal. On another study, we have an overt iron deficiency anemia. But we also have 2 stages in between. One of them is a negative iron balance, and the other one is where we have iron deficient erythropoiesis. We'll call both these categories as latent iron deficiency, which means that it is not overt, but it is very much eminent. So if such people are allowed to donate, more often, they would very easily become iron deficient anemic donors if they're allowed to do so. So there's very interesting study which was conducted at a center over a period of 3 months in blood donors who, of course, who were taking any iron supplement were excluded. The statistical sample size was 496. We ended up doing a little over 500, 501 to be precise. Pre-donation finger prick hemoglobin was 12.5 gram %. So only donors who were accepted according to the regulatory guidelines were included. And their EDTA samples, which is collected for the blood grouping, was used for doing another test. We'll see what test. The test was RET-HE, called reticulocyted hemoglobin. And these are the results that out of 501 donors, there was 97% men and 3% women. And this is approximately the gender distribution all over the country in India. So India, there are very, very few women donors as compared to men donors. The average age was 30 years. There were first-time donors who were donating for the first time ever in their life were 18%. Repeat donors were those who had donated earlier in their lifetime and were donating again, were repeat donors. And the regular donors were defined that people who had donated at least once in the preceding year were 41.9%. So 18, 40, and 40 approximately was the distribution among for first-time, repeat, and regular donors. RET-HE, the newer parameter, which is possible with the cell counter. So this is a very easy way of finding out. This is the early RBCs where you can find out the reticulocyted hemoglobin. And this was compared with the gold standard in this study, which was serum transferrin receptor. And this is the 2x2 table for the RET-HE with comparison to the gold standard STFR. And this, on basis of which we found that sensitivity of RET-HE was very high, 91%. And the specificity was even higher, 97.2%. But more importantly, from this presentation perspective, we found that percentage of women donors who had latent iron deficiency were far more common than men. So 60% women had latent iron deficiency as compared to 26% of male donors. And this is very similar to results published from Chandigarh by Mittal et al. If we look at the first time, repeat and regular donors, we found that latent iron deficiency was 17.6% in first time, 20% in repeat donors, and 37.6% in regular blood donors. So this is a real risk in our setting. So we need to be very, very careful in donors who donate again and again. We need to take a special care of such donors to ensure that they continue donation. So on one hand, we would like many donors to donate. And therefore, it is very important that we mitigate the risk of anemia, we mitigate the risk of latent iron deficiency in such donors. This is, of course, the example of the advantages of RET-HE, that it does not require a batch processing. You can run a single sample. And this is very, very simple. You just have to put it in a cell counter and you get the value. It is also very economical as compared to STFR. So earlier, ferritin used to be the gold standard in most of the studies, but RET-HE is easier than the ferritin. And ferritin is also an acute phase reactant, but RET-HE is not an acute phase reactant, so is more accurate even in patients who are having some kind of inflammation or infection in their body. So the study concluded that RET-HE can be used as a reliable test for diagnosing latent iron deficiency amongst blood donors. And the study recommended that its routine testing should be done, especially in women donors and regular donors, because that may provide an opportunity to make appropriate interventions like dietary changes or iron supplementation, and thereby stopping progression to overt iron deficiency anemia. This was published in Vox Sanguinis in 2018. Now we need to understand the mitigation strategies, since we know that iron deficiency is a real risk. We know that donors who are at risk are younger donors, the premenopausal women, donors who donate frequently, and donors whose hemoglobin value is just about 12.5 gram%. The prevention strategies are that we can think of iron supplementation. We can at least increase the interval between two donations, which has been done in 2020 Gazette notification. So men can donate every 3 months and women can donate only after 4 months. So they have increased the duration between two donations for women. And I believe that iron deficiency anemia was one of the reasons for changing that interval. Measurement of ferritin and RET-HE should be considered very actively. So there has to be a mechanism of first identifying as to who are more susceptible, and then possibly giving them proper dietary consultation or iron supplementation if needed. And of course, any such thing needs to be monitored as to how good it is happening. There's a very interesting study from PGI Chandigarh, a randomized control study to evaluate effects of short-term oral iron supplementation in regular voluntary blood donors. Dr. Gopal is also one of the authors. The hemoglobin and ferritin levels show significant improvement in iron group compared to placebo group. So it was a very nicely done study. They had a placebo group and they had a group which was receiving iron. And 3 weeks of oral iron therapy, and which was almost 100 milligram elemental iron a day, was able to maintain iron stores for 1 month after donation, but was not sufficient to sustain iron stores over a period of 3 months. And therefore, they recommended that there's a need to evaluate a higher dose or maybe duration of iron supplementation in maintaining the iron stores. So even there, it's not easy. So there is a challenge of providing iron to donors for a substantially long period of time to ensure that they do not become anemic or have latent iron deficiency anemia. So to summarize the entire talk, There are few beneficial effects of blood donation, like reduced systemic heart disease, have been reported in the West, but they may not really apply to our population. Adverse donor events are immediate or delayed. Delayed adverse reactions are again short-term, which occur in days to weeks, or long-term, which occur in months to years. Common short-term delayed adverse reactions are bruise, sore arms, and fatigues. Mitigation is by educating donors, the BTS staff, and taking a special care of first-time, younger, and women donors, because we know that these category of donors are more likely to have them. Current apheresis guidelines adequately protect the skeletal health of even high-frequency apheresis donor, and there is no reduction of immunoglobulins or immunity by repeated plasmapheresis donation. However, anemia, the long-term delayed adverse reaction, is quite common in women donors, especially in women donors and regular donors, and mitigation involves detection and deferral. Reduced frequency of donation has been done recently for women donors, increasing it from 3 months to 4 months, and considering diet or hematinic supplementation. Thank you very much.
Thank you, Dr. Asim, for giving an elaborate talk and telling us about the various short-term and long-term delayed adverse donor reactions. So I think we can have discussion after the second talk. So I would now request my co-chair, Dr. Debashish, to introduce the next speaker.
Okay. Thank you, Dr. Asim, for a very good presentation on the delayed adverse reactions and its mitigation strategy. I sincerely apologize because there's some technical hitch in the beginning for which I couldn't join, and but it was later sorted out. I am pleased to introduce our second speaker of the session, Professor Rajendra Chaudhary, who is head of the Transfusion Medicine Department as SGPGIMS Lucknow. Dr. Chaudhary is known to everybody, and he doesn't require any further introduction to our participating delegates. But just as a rule, I'm just introducing him. He is a former member of the NB National Blood Transfusion Council and a member of various societies like Technical Resource Group of the NACO, the Executive Committee of the SBTC of Uttar Pradesh, and coordinator of specialty of Board of Medical Council of India. He was a former member of the ISBT Academy and the former founder secretary of the Indian Society of Transfusion Medicine. He is a recipient of several awards, which we know from his CV, as it is mentioned, and he is also a visiting scholar to the Department of Transfusion Medicine at Mayo Clinic, USA. Dr. Chaudhary has supervised several MD theses in transfusion medicine across the country, and he's been an external examiner for MD transfusion exam at various institutes in India and Malaysia. Dr. Chaudhary, over to Dr. Chaudhary for his presentation.
Yeah, good morning, everyone. At the outset, I would like to thank the organizing committee of this CME for inviting me to deliver this talk on effect of donor factors on transfusion outcome. We all know that blood components are considered as drugs. Likewise, a transfusion of this component should result in favorable outcome in the patient without any adverse complications. So how do you measure this transfusion outcome in a recipient? So there are multiple clinical as well as laboratory parameters available to assess the transfusion outcome in patients. So example is increment in hemoglobin or hematocrit following transfusion of red blood cells, or increment in platelet count following transfusion of platelet concentrate. Similarly, mortality rates, survival rate, length of hospital stay, bleeding score, incidence of adverse reactions. So they are all parameters to assess the transfusion outcome in in any patients who have been transfused. It has been well established in the literature that there is biological variability in blood units, which means that all the blood units are not same. And this variability in the blood unit is reflected in the variation in quality of an individual unit. So all the blood units, the quality will not be same. There will be a lot of variation in the quality. And this variation in the quality will in turn affect the transfusion efficacy and the patient outcome. So there are various factors. So there are various factors which affect the variation in the component quality. So they are broadly categorized into 4: the donor-related factors, factors related to production of the blood components, factors related to post-production manipulation of the component, and the storage-related factors. So in donor factors, the donor may have some genetic defects such as enzyme deficiencies. The most common deficiency is the G6PD deficiency, hemoglobinopathies such as the thalassemia trait or sickle cell trait, age of the donor, gender, ethnicity, lifestyle of the donor, that is history of smoking, alcohol, obesity, or history of medication. With regard to production related factors, what kind of method is used, whether it is a Buffy-Coat method or PRP method, whether it is a whole blood derived component or apheresis derived components, what is the holding time before processing of the component, what kind of plasticizers are used, leukoreduction, and whether the process was automated or manual. Then coming to the post-production related factors which can affect the quality. So irradiation, pathogen inactivation of the component, washing of the component. So they are all associated with, they will all affect the quality of the blood component. Then storage related factors like what is the time or duration of the storage period and whether there is a freezing involved or no freezing. So all these factors, they affect the component quality. And this will in turn affect the transfusion outcome. If the quality is not good, then the transfusion outcome will also not be good. So there is one study published from India. This article is published in journal Blood Transfusion in 2014. So in this study, the authors have observed variation of nearly 100% in the total hemoglobin content of the RBC unit tested. So in their study, there was 100% variation in the hemoglobin content of the units. And it was ranging from 42 gram per unit to 80 gram per unit. So it's a wide variation in the hemoglobin content in RBCs. So therefore, the authors recommend that it would be prudent to label RBC units with their total hemoglobin content. So because of this, a lot of variation in the quality of blood components. Now coming to various factors which can affect the transfusion outcome. So again, they are classified or broadly divided into 4 blood donor factors. So like donor demographics, the age of the donor, gender or the race of the donor, donor lifestyle like history of smoking, alcoholism, body mass index. Then the donor may have some undiagnosed or diagnosed comorbidities which will affect the transfusion outcome. Then there are some storage related factors like what is the age of the component, whether additive solutions have been used. Then factors related to transfusion of blood component like what was the timing of transfusion, how much volume was transfused, what was the indication for transfusion. And then there are patient related factors. So like what is the age and gender of the patient, what was the diagnosis of the patient, or if there is any undiagnosed or diagnosed comorbidities available in this patient. So all these factors, they affect the transfusion outcome. In today's presentation, I'll confine myself to only blood donor related factors. So the presentation today is focused on factors, donor factors affecting the transfusion outcome. So I'm going to confine myself only to these factors and their effect on transfusion outcome. So coming to the first factor in the donor, that is donor demographics and its effect on transfusion outcome. So age, gender, and the race of the donor. So this is one beautiful study published in Journal Transfusion in 2019. So it was a retrospective analysis of 93,000 patients who received 4,28,000 RBC units. So in this retrospective analysis, they studied association between blood donor characteristics such as age of the donor, BMI, hemoglobin level, smoking status, and its association with hospital mortality and post-transfusion length of hospital stay in the recipient. So these are the factors, donor factors, and this was the transfusion outcome. So they wanted to see the association between these two. So in their study, they found no association between blood donor characteristics and hospital mortality. However, with regard to hospital length of stay, there was an association with the age of the donor. They found that the receipt of RBC units from donors who are less than 20 years of age was associated with shorter hospital length of stay. So there was no association with hospital mortality. However, the age of the donor was associated with hospital length of stay in the hospital. So this is the effect of age of the donor on the transfusion outcome. Then there is another study published in Blood Advances in 2017. Here, they have studied the race of the donor, gender, and age, and its effect on red cell hemolysis during storage. And as you know that if there is a hemolysis during storage, it will adversely affect the transfusion outcome. So they found that male sex was strongly associated with increasing susceptibility to storage-induced hemolysis, osmotic hemolysis, and hemolysis due to oxidative injury. So they studied these three types of hemolysis during storage of RBCs, and they found that if the donor was male, then it was associated with increasing hemolysis during storage. With regard to the race of the donor, Asians and African American donors were associated with significantly higher storage hemolysis compared to whites. So these findings highlights the impact of donor factors on hemolysis during storage, and which will in turn affect the transfusion outcome. So if there is an increasing hemolysis in the blood unit during storage, it will naturally affect the transfusion outcome. So this is yet another study published in Blood in 2019. So in this study, they have seen the effect of donor characteristics, component characteristics, and the recipient characteristics, and their effect on hemoglobin increment following red blood cell transfusion. So this was again a retrospective analysis, and so there are they studied the factors affecting the hemoglobin increment in transfusion recipients. So what are the factors like blood donor factors? So they found that if the donor was male, the age was less than 70, and if the donor was RSD positive, then it was associated with increased hemoglobin after blood transfusion. So increase in the hemoglobin increment after blood transfusion. Coming to the component related factors, so they found that if the unit was collected by apheresis, if there was a gamma irradiation done, and if the storage duration was more than 35 days, it was associated with decreased hemoglobin increment following blood transfusion. Coming to the recipient characteristics, if the patient was female, positive for RSD, with lower BMI and lower hemoglobin level, they were all associated with increase in the hemoglobin increment following blood transfusion. So you can see that there are various factors, donor related factors, component related factors, and the recipient related factors. They have effect on transfusion outcome in the form of hemoglobin increment following blood transfusion. So we also tried to analyze our data for 10 years from 2009 to 2019. And we have seen the effect of donor age, gender, and method of preparation of blood component on total hemoglobin content. So we do quality control studies in our department routinely. And so this was the data of those quality control investigations. So it was a retrospective analysis of about 2,500 units, which were obtained from 350 ml of whole blood, and about 2,800 units, which were obtained from 450 ml of whole blood. So they were all subjected to quality control studies in a period of 10 years. So we found that the donor age, gender, and method of preparation, they were significantly associated with total hemoglobin content of the unit in both 350 ml as well as in 450 ml. It was statistically significant. In method of preparation, we found that top end of the method was associated with increased hemoglobin content. If the age of the donor, we found that if the donor age was less than 45 years of age, then the hemoglobin content was better as compared to those where the donor age was more than 45 years. And male donors were associated with increased hemoglobin content in the blood unit. So you can see there are various factors which affect the hemoglobin content, and naturally if the hemoglobin content is low or high, it will affect the transfusion outcome accordingly. If the hemoglobin content is low, the transfusion increment, hemoglobin increment following transfusion will be low. If the total hemoglobin content in the unit is high, the transfusion outcome will be favorable. So you can see that the donor age and hemoglobin content of the unit. So this is the PRBCs obtained from 350 ml of blood, and this is the PRBCs obtained from 450 ml of blood. And there are 3 age groups, so above 45 to 60 years. So you can see that we found that low mean hemoglobin content in PRBCs obtained from donors of 45 years of age and above. So if the donor was more than 45 years of age, the total hemoglobin content was low in 350 ml as well as in 450 ml of blood. Now coming to the gender of the donor, so far we have discussed the age of the donor. So now coming to the gender and its effect on the transfusion outcome. So here I have tried to summarize 3 very good studies published in the literature. This is one study published in JAMA in 2017. They found that increased risk of mortality in male recipients from red blood cells obtained from female donor with a reported history of previous pregnancy, but not from females that did not report pregnancy. So this is a very interesting finding, that increased risk of mortality in male patients if they were transfused from a female, the unit obtained from female donor with history of pregnancy, but not from females that did not have a report pregnancy. Then there was another study published in JAMA Internal Medicine in 2016. So they concluded that each unit of RBC obtained from a female donor was associated with 8% increased risk of death. This is a very significant thing. Each unit of RBC from a female donor was associated with 8% increased risk of death compared with exposure to male RBC. And third study, they found increase in the hospital mortality rate when males were exposed to female RBCs. So you can see that the gender of the donor also affects the transfusion outcome. In our study, we also tried to find out the effect of gender of the blood donor on hemoglobin content. And we found that this was all, the units were obtained from 350 ml only, because we bleed female donor only in 350 ml of bag. So we tried to analyze the effect of gender, and we found that the mean hemoglobin content of blood units from female blood donor was significantly lower. So these are the female donor and these are the male donors. Then it was significantly lower from as compared to male blood donors. In female, it was 37 gram per unit. In males, it was 41 gram per unit. So you can see that the gender of the donor also affect the transfusion outcome. So what is the mechanism? Why a donor gender is associated with unfavorable transfusion outcome in the recipient? So there are various hypotheses. They are not yet proved. They are just hypotheses. They have been postulated. Like one mechanism is in male units, the RBCs obtained from male donor, excess of free hemoglobin is available in the unit. And so it because of this excess of free hemoglobin, it overwhelms the scavenging capacity of the reticuloendothelial system in female recipients. So this is one hypothesis. Second, this free hemoglobin is converted to methemoglobin. And this conversion is facilitated by nitric oxide. And as a result of this, there is less availability of nitric oxide in the unit. And as you know that nitric oxide is responsible for endothelial function, and it also prevents oxidative injury. So if there is less of nitric oxide available, then it will result into endothelial dysfunction as well as oxidative injury. The third mechanism, the male RBCs are more denser and they are less deformable. So therefore, they will affect the microcirculation. They will affect the margination of the red cell in the capillaries. So these are various mechanisms proposed why male RBCs may be harmful to females. As opposed to this, another mechanism why female RBCs may be harmful to male. So this is again one hypothesis suggested that there is a subpopulation of erythroid precursors in young females, which are enriched in immunosuppressive cells. And they have been shown to impair the defenses against pathogens in neonates and cancer patients. So these are all mechanisms postulated, but they have not been yet proved. Then this is another study where they have seen the effect of sex mismatch transfusion and mortality. Sex mismatch means the male recipient getting blood from a female donor or female patient getting blood from a male donor. So this was a systematic review and meta-analysis. They included 5 retrospective observational studies with patient size, sample size of 86,000 patients. And they concluded that sex mismatch RBC transfusions were associated with a higher risk of death compared with sex match transfusion. And the hazard ratio was 1.1. So this is a very significant finding. If there is a sex mismatch in the RBC transfusion, it was associated with higher risk of death. But interestingly, they concluded that the data was prone to confounding. There was a selection bias, there was a reporting bias, and therefore the evidence, the level of evidence was very low. So we have to take all these findings with a pinch of salt, that they are just observations. So there is no case control kind of studies. So these are just observations. So, and they are all prone to confounding factors, selection bias, reporting bias, and the evidence is very, very low. Now coming to the third donor factor. The donor may be having some underlying diagnosed or undiagnosed conditions like G6PD deficiency, thalassemia trait, sickle trait, and that will definitely affect the transfusion outcome. So most common deficiency in the enzyme is G6PD. In India, the prevalence is about 3 to 5% in general population. So this is the very commonest form of enzyme deficiency in our blood donors. So so in this study, they tried to find out the effect of transfusion of G6PD deficient donors in the recipient. And they found that the post-transfusion RBC recovery was 78% if it was G6PD deficient donor as compared to normal RBCs. So definitely G6PD deficiency in blood donor has adverse effect on the quality of stored red cell, and which will indirectly affect the transfusion outcome. So this is one problem in the blood donor which can have adverse transfusion outcome. Coming to donors with hemoglobinopathies. So you know that thalassemia is very common in certain parts of India. Again, it is about 3 to 4% the incidence, and thalassemia trait will have a normal hemoglobin level, and so they will be eligible to donate blood most of the time. Similarly, sickle cell trait patients or donors, they are also common in certain parts of India, for example, in central India, and they may have hemoglobin about 12.5, and so they will be eligible to donate blood. But the red cell from these donors during storage they show impaired rheological properties. So it will affect the microcirculation after transfusion in the recipient. The red cells from these donors, they are more susceptible to oxidative hemolysis during storage. There are red cell deformities in the RBCs from these kind of donors, and RBCs, they will have shortened in vivo lifespan in both the condition, in thalassemia trait as well as sickle cell trait. So you can see that the red cells have a lot of problems, and definitely if the unit is transfused to a patient, then it will have not very good outcome, transfusion outcome. Now, third donor factor which can affect the transfusion outcome is donor lifestyle, like history of smoking, whether the donor is obese, or if there is alcoholism, history of alcoholism, then it will affect the transfusion outcome. So coming to the history of smoking, so it has been seen that RBCs from chronic smokers, they show 280% increase in hemolysis when exposed to peroxidants. So they are susceptible, they are prone to undergo hemolysis from the RBCs obtained from smokers. The RBCs show extensive RBC membrane deformities. With electron microscopy, they have demonstrated that the RBCs from smokers will have membrane deformities. There is loss of discoid shape of RBCs and reduction in the in vivo lifespan from 120 days in normal RBCs to 80 days in smokers. So if you obtain a unit of blood and from a smoker, chronic smoker, it will have all these problems. And naturally, if you transfuse the unit to a patient, the transfusion outcome will not be favorable. And as per our donor selection criteria, chronic smoking is not the criteria for deferral. So we continue to accept the donor who are chronic smokers, and we continue to transfuse the blood obtained from these donors, and the recipients will not have very good outcome because of these various changes in the RBCs. So this was one study published in Transfusion in 2019. In this study, they have seen the effect of red cells donated by smoker and its effect on transfusion outcome. So this was a very good study. So the donor units were tested for nicotine metabolite, which is cotinine. Cotinine is a metabolite of nicotine. So this was measured in the blood units obtained from smokers, and also they measured the carboxyhemoglobin. And they found that there was a significantly greater carboxyhemoglobin content in cotinine positive units compared to cotinine negative units. And these cotinine positive as well as cotinine negative units were transfused to the patients. And they found that if the patients were transfused with cotinine positive units, the post-transfusion increment in the hematocrit as well as in hemoglobin was less as compared to the patients who were transfused with cotinine negative units. You can see that these are the cotinine positive units. This is the hemoglobin and this is hematocrit. And this is the patient who received cotinine negative units, the post-transfusion hemoglobin and post-transfusion hematocrit. So you can see there is a statistically significant difference in cotinine positive versus cotinine negative. So definitely the red cells obtained from smokers, they have not good transfusion outcome in the form of post-transfusion increment in hemoglobin or hematocrit. At our institute, this study is ongoing. This is intramurally funded project. We are trying to see the effect of smoking on platelet function in apheresis blood donors or in apheresis concentrate, platelet concentrate, not in the donor. So this is an ongoing study. So far, we have included 15 smoker blood donors and 8 non-smoker apheresis donors. The apheresis were platelet concentrates were obtained from these donors and they were stored for 5 days. We studied platelet indices, thromboelastography, platelet aggregation using ADP and collagen, and the platelet mapping was also done. We found that there was a progressive loss of platelet function in platelet aggregometry in smokers from day 0 to day 5. So there was a progressive loss as demonstrated by platelet aggregometry. And there was a decreased hemostatic potential in smoker platelets as compared to non-smoker. And this was demonstrated by thromboelastography and platelet mapping. So this study is still ongoing. It is not yet complete. So you can see that there is effect of smoking on platelets also, in addition to red cells. The another lifestyle factors, donor factor, is the obesity. Obesity is defined as a BMI of 30 kg per meter square or more. In obese donors, there are certain changes, alterations in the RBC metabolism. There is increased susceptibility to hemolysis. There is a 25% reduction in the deformability, increased membrane rigidity, increased formation of reactive oxygen species. There is increased expression of pro-inflammatory markers in RBCs obtained from obese blood donor, and there is increased RBC aggregation. So you can see that various serious changes are happening in the RBC metabolism in obese blood donors. And naturally, the red cell transfused from these donors will have unfavorable outcome in the recipient. So this study is published in Transfusion very recently in 2021. They have studied the obesity in blood donor and its association with changes in red cell metabolism and susceptibility to hemolysis during storage. So they obtained the red cell from the obese donor, and they studied effect of they studied the various kinds of hemolysis: storage-induced hemolysis, osmotic hemolysis, and oxidative hemolysis during storage of RBC. So you can see that there are three categories of donor. This circle, empty circle, is donor with less than BMI, 25 BMI, which is the normal blood donor. Then there are overweight blood donors, that is squares, which is 25 to 30. And solid triangles, they are obese blood donor, that is more than 30 BMI per kilogram per meter square. And this is the storage week from 1 to 6. And this is the storage hemolysis, percentage of storage hemolysis. So you can see that in obese donors, which is the solid triangles, you can see that there is a very significant progressive hemolysis during storage of RBC at 4 degrees Celsius as compared to normal RBCs. The circles are normal. So leukoreduced RBC units were obtained from 18 donors. They were stored for 6 weeks and hemolysis was measured. Three kinds of hemolysis: storage-induced, oxidative, and osmotic. And they found that the hemolysis was increased during storage in obese blood donor. So obesity is associated with increasing susceptibility to hemolysis under routine storage of RBC units. Another study, higher body mass index is associated with increased hemolysis of red cell at 42 days of storage. So they also tried to find out the association between higher body mass index of the blood donor and hemolysis during 42 days of storage. And you can see that the hemolysis, percentage of hemolysis, the 4 categories of donor: underweight, healthy, overweight, and obese. So you can see that in overweight as well as in obese blood donor, there was a significant hemolysis during 42 days of storage as compared to underweight and the healthy blood donor. So donor BMI more than 27 kilogram per meter square is associated with increased hemolysis during cold storage of blood. So far we have studied various donor factors and their effect on transfusion outcome. But they are all observational studies. The drawback is they are all observational studies. There are no case control studies or randomized trials. So we have to take the results of these studies with a little pinch of salt. And this highlights, this review, meta-analysis, which is published in Transplant Medicine Review, it highlights this fact. So they have done a systematic review and meta-analysis. 59 studies were included, and the objective of this study was to assess association between donor characteristic and transfusion outcome. And they studied 17 donor characteristics and its effect on transfusion outcome. So it was a very beautiful study, very large sample size and meta-analysis. So what was the result of this? So based on very low to low quality evidence. Some donor characteristic may affect the outcome. So according to their analysis, they found that the evidence is very low. However, some donor characteristic may affect the transfusion outcome. And for example, they found that there is association between donor sex and decreased survival of the recipient at 90 days, male recipients. So if it is a sex match, a mismatch transfusion, then there was an increased risk of deaths, and the hazard rate was 2.6%. Other than this, there was no association with any of the donor factors. And the evidence, even for this observation, they say that the evidence is insufficient to draw definitive conclusions for any donor characteristics. So you can take a lesson or take a message from this, that all these studies are published on the donor factors affecting the transfusion outcome. But so far, not a single randomized control trial has been done. They are all observational studies. So we have to take these results, we have to read these results very carefully. And because the evidence is very, very low, insufficient. So finally, I would like to conclude my talk that blood donors are demographically and genetically diverse group of individuals, and therefore donor differences in the donor characteristics may play a role in the recipient outcome. The result of observational studies have been disparate. We have seen that some of the studies show the gender of the donor is important. In some studies, it is the age of the donor. In some studies, it is the smoking or the body mass index. So results are not uniform. They are disparate. And some analysis finding that patient transfused with red blood cells from female donor or specific donor age groups have increased mortality, while other findings, studies find no such association. So there is no uniformity in the literature. Some studies, they are finding some association, while others, they are finding no association. So the one large meta-analysis, which I have shown you, which was published in Transfusion Medicine Review, they concluded that there is low to very low evidence for this association of donor factors on transfusion outcome due to following reasons. So they have given some reasons why the evidence is very, very low. Because there is a difference in the population studied, sample size, difference in the studied sample size, differences in the recipient type. They are not uniform. Some patients are having hemato-oncological patients, some may be having simple anemia, or some may be undergoing surgery. So there is no uniformity in the recipient types in all these studies. Then there are missing data, proportions of missing data. The statistical method used is also questionable. There is a reporting bias, and then there are confounding factors also, which have not been taken into account. So because of all these factors, the evidence is low to very low for the association between donor factors and transfusion outcome. So what is the way forward? So we need a multicentric, prospective, randomized control trials are needed to fully establish any association between donor characteristics and transfusion outcome. Thank you.
Thank you, Dr. Chaudhary. That was a, can my video be activated? Am I audible? Yeah. That was a very good presentation. Dr. Chaudhary has given a very good insight into the characteristic of the donor in the transfusion outcome. This is really eye-opener, and we must, though their evidence are low, but some randomized control trial should be carried out as a research work to find out whether the donor characteristic really affect the transfusion outcome. Okay, so I think any question is there in the chat box for the two speakers? No, there's no questions as of now. But I must say that Dr. Asim, he has presented a very good thing about the delayed adverse reactions and the two short-term and the long-term cases. But what we have observed that most of the blood center, they don't give their contact number in the outdoor blood donation camps. Okay, so there is no way many of the donors, they are not aware that they have donated in which blood center. Okay, so if such type of adverse reaction happens in the short term, like allergic reactions or something, what steps should be taken? Like many of the centers, they have the SMS facilities where they can contact, but those centers which doesn't have, how we can tell them that this is how the donor to develop a short-term or the long-term DAR, they can approach the blood center.
Sir, I think we'll still have to depend on pamphlets or display of information. What I'm only trying to say that our tele density in our country is very high, so almost everybody seems to carry a mobile phone. So I'm just trying to say that this is one of the things that can be looked upon maybe in coming times, that what has happened, that now that we send a message to every donor and there's a link on which the post donation instructions are available, it also provides certain element of safety. So suppose a donor goes out of the premises and has an accident, and the court of law asks us that whether you provided the instructions to the donor, we can actually produce that evidence that yes, we did. And donor reactions can still happen, and there may be sometimes even injuries because of delayed adverse reactions, but the legal responsibility was fulfilled and the donors were asked to take rest and was asked to take fluids and were asked to report any adverse reactions back to the blood center.
Okay, I was very much impressed by your paper where you have personally given a telephonic interview after the donation with the donors. So that is a huge number of donors you have interviewed.
Yes,
so, but that may be the short-term, to identify short-term DR, or the long-term DR also been included in the study?
We have done only short-term DARs, not the long-terms. And the long-terms are largely in anemia, where a lot of work has been done by PGI Chandigarh in a paper by Mittal et al. And paper by Dara et al. So they have done very, very good work in the iron deficiency anemia in donors who donate more often.
Okay. Any questions from Dr. Ravneet?
I think there are no questions, but I would just like to compliment both the speakers. Both the talks were thought-provoking. We need to look at the delayed donor adverse reactions. And at the same time, as Dr. Chaudhary has pointed out, that we need to have some evidence generated in the country. We need to have multicentric study to look at the impact of the donor characteristics on the transfusion outcomes. So I thank both the speakers, and I think we can hand over this mic to Dr. Haim, who will take the proceedings further.
Thank you,
ma'am.
Thank you,
From my side, I thank Dr. Asim and Dr. Rajendra for the very good presentation and very thought-provoking presentation, which will be very effective in our routine transfusion practice.
Thank you, sir.
Thank you very much, ma'am. Thank you for being here. May I have the panelists on the screen, please? Dr. Meenu ma'am, Dr. Geetanegi ma'am, Dr. Somnath sir, and Dr. Vijay. Okay, so good afternoon, everyone. I'll be moderating this panel discussion. We'll have a few topics which we face problems on day-to-day basis. And we have among us 4 specialists from our country who are actively involved in a lot of work in these aspects. So let me first introduce Dr. Somnath Mukherjee sir. He is additional professor and HOD in AIIMS Bhubaneswar. His work experience is 14 years and he has a number of honors and achievements and awards. He has more than 35 publications and he is member of a number of transfusion societies. He is in addition reviewer of MD thesis and Indian Journal of Hematology and Blood Transfusion, PLOS One, and many other journals. The second panelist is Dr. Meenu Vajpayee ma'am. She is Professor Transfusion Medicine, Institute of Liver and Biliary Sciences, New Delhi. She has done her MD Transfusion Medicine from PGI Chandigarh in 2003, and she is a member of a number of societies, and she is convener of SIG on therapeutic apheresis, member committee of National Policy on Hemoglobinopathies. She is an external faculty for NHM training of blood bank staff from the different states of India, and she is technical resource person in blood banking for MP State AIDS Control Society. She is also a faculty for PDCC course on apheresis technology, immunohematology and blood banking, as well as transplant immunology in ILBS. The third at the list is Dr. Geeta Negi ma'am. She is professor in HOD Department of Transfusion Medicine and Blood Bank, AIIMS Rishikesh. Ma'am has done her MBBS in 1994 from King George Medical College, MD in 1999 from King George Medical College, Lucknow. She has fellowship of AIIMS in 2014. She is fellow transfusion medicine from ATOM at National Blood Transfusion Center, Colombo in November 2016. She has interest in regenerative medicine, apheresis, quality management systems, and medical education. And she had a number of awards, like she was given a Best Teacher Award from Chief Minister on 2013. She has received Best Teachers Award at AIIMS Rishikesh in 2021, and so many other awards, as well as she had around 60 publications overall. The fourth panelist is Dr. Vijay Kumawat. He is Associate Professor, Transfusion Medicine and Hematology at AIIMS, Karnataka. His areas of interest are therapeutic apheresis, quality management system, donor recruitment and retention, and basic neurosciences. Previously, he was assistant professor in the same department, and before that, he has worked as consultant HOD in Citizens Hospital and other places as well. So I welcome all the four participants. Now coming to the question, my topics will be directed to one of the panelists, although I hope all the panelists would be actively involved in answering. So please bring all the panelists to the screens. Yeah, so the first question would be regarding the donor-informed consent. We are routinely taking donor-informed consent, but most often we forget to take consent in verbal. We don't tell the donor what is going to happen most of the time, either because we are more busy with our work, or there are so many blood donors which we need to take care of. But let us see why it is required. What are the ethical issues related with it? So I would first invite Dr. Vijay to answer this question. Why donor-informed consent is necessary? What are the ethical issues related to this donor-informed consent, and what should be the format of this donor-informed consent? Whether the consent which we are taking on the donor history questionnaire is itself sufficient, or shall we go for a verbal explanation of these issues also? So, Dr. Vijay.
Yeah, thank you, Dr. Haim. So first, I would like to thank the organizing team for the CME for inviting me. So yeah, issues important. So as we all know, in medicine, the concept starts with the informed consent. It's not consent, it is called as informed consent. So which automatically implies that you have to inform first and then take consent of whatever procedure we are doing. So blood donation is a medical procedure which is associated with various adverse events also. So donor need to be informed prior to, and donor has the right, because he is donating, then what is going to happen with the blood, what test we are going to perform. Then because now in the recent 4 to 5 years, we got plasma fractionation policy, which got legal sanity after this recent DCA amendment. So that becomes legal bounding also, that we inform the donor that it may go for bulk transfer, it may go for fractionation also. And I would prefer that we should also include that if for any reason, maybe that QC is failure, so it is not going to be used for any clinical purpose. That also, because donor should not feel bad. It's his right that there may be certain situations where this blood won't be suitable for clinical use, and we may use maybe for QC purpose, because few unit we divert for QC purpose also, which doesn't go for clinical utilization. So it should be like informed consent. We have to explain in detail. So that's what the role of our counselor come into the picture, where the counselor can give a brief orientation that what we are supposed to inform, that can be briefed up. And if donor has any queries and all, it can be answered by medical officer or the doctor who is there in transfusion services. So I think
I think you mean to say that it is not the implied consent. Most of us think that donor has presented to us, so he already knows that he is about to enter into some medical procedure. So it has to be verbal as well as it has to be a written consent. That's what I feel you mean.
It's no way it's implied consent. It is informed consent. We write it as like we are writing it as an informed consent.
Okay. Okay. So the next question is, as you rightly said, we have started a number of other things in the past 2-3 years, like fractionation. Blood banks are involved with telling the donor about his TTI. So consent has to be TTI results, or consent has to be taken for all of them. So what else can be the content for the consent? Like only blood donation, or like we are preparing components. So shall we inform the donor that we are not using whole blood but processing it into components? We may be discarding it. So would this form a part of consent, or only that blood donation or its risk are a part of consent?
No, so the utilization part also I feel we should cover. So we have covered up that this will be processed into various components. This may undergo the TTI levels, and for any certain reasons which may be specified, like if it is TTI reactive, or it may not fulfill the quality control criteria, or any other condition which may make the donated unit unsuitable. So that won't be utilized as a for clinical transfusion purpose.
Okay. So any other thing which other panelists want to add? Minu ma'am, would you like to add something?
No, I was just thinking about one aspect which has recently come up in discussions, that does the donor have a right to know where the blood is being transfused? Many blood donors have raised this issue that we want to know who was given our blood. And as a standard practice, blood banks never inform this. So there's some ethical issues about this. Was a new topic which I recently came across in a discussion, that should donors be informed? I would like to listen to the comments of the panel on this. Anybody?
Yeah, so what I feel, this is breach of confidentiality, both for patient, like from patient point of view and donor point of view. So the rights stops where other person right starts. So we should not mix up. Donor may have right to inform that on this date his blood was transfused to any or was clinically utilized. That we can think of. But revealing the identity of a person that, okay, your blood was given to XYZ, that is ethically not correct.
Okay.
Absolutely, I agree. Yes, I agree with what Dr. Vijay and Dr. Minu just now said. Absolutely, you definitely need to tell that is going to happen to the blood unit that you've collected, but you need not tell them who it was given to. Confidentiality is one of the very essential tenets in our branch. So this is something that has to be respected.
Okay. Sir, continuing in the same topic, I would like to direct my next question to Dr. Somnath, sir. I know that he was a part of ethical committee of his institute for the matter. So, sir, we need consent for other things like clinical transfusion or fractionation. But a lot of people are now requesting these samples to be used as controls in a number of research projects. So what about consent for that? Can we take a blanket consent to every donor that we'll use your sample? We may use your sample as a control or for any research purpose, or we need to take a separate consent, or how do we go across this? What are the ethical issues associated?
Yeah, can you hear me? Can you hear me?
Yes, sir. Yes, sir. Okay. You are audible, sir.
Yeah. So thank you, Dr. Haim and Dr. Gopal and the whole organizers for giving me this opportunity and invited me in this seminar. So yeah, it's a very interesting and very challenging thing. Whenever we would like to take samples from donor, or during the time of donations, we would like to take samples and do some research or use the sample as a donor control sample. So I think whenever we are going to perform any kinds of research with the donor sample, we need to have a separate consent, making them understand, and with informed consent with the I am going to do, what is the purpose of research, are you willing to participate, are you willing to give your samples for the research purpose. So whatever, apart from your donations, I mean, with that particular consent, whatever during the donation you are giving, they are giving, but separate consent form is mandatory whenever we are going to perform any kind of research with his or her sample. So that is a mandatory from ethics point of view. Even with the leftover sample, even sometimes people say, okay, I have some leftover samples of the donor, so and I would like to do some further tests for my particular research purpose. So even in those situations and those conditions, beforehand, you have to take the consent from the donor that I am going to perform this kind of test, and would you like to let me allow to handle your sample and do some tests? Otherwise, it would be unethical, because anytime we can land in a trouble.
Okay, sir. I completely agree with you, sir. However, this may be possible only in prospective studies, sir, right?
Yeah, obviously, whenever you are taking sample, I mean, you are doing some studies, but even with the retrospective studies, if you have your, I think you can't, because we need to have we need to take the consent from the donors, because we can't, without taking the consent from the donor sample, I mean, from the donor, we can't use the sample or the donor issue, because this is a tissue of the donor, and it has every right to know what we are going to do with this tissue. So, but for the control purpose, like say, I'm going to do some routine tests, like in platelet aggregation studies. Sometimes we take a routine control, or some coagulation studies. We are taking the sample, plasma samples, so control study for routine patient service, hospital investigations purpose. So in those situations, I don't think we need to do some, we need to have this kind of, but obviously for research purpose, whatever, whether it's prospective or retrospective, we need a consent.
Okay, sir. Even if we are doing it on some stored samples, sir? Like it is a habit of mine that I store samples.
Yes, I just talked to that leftover samples.
Okay,
even the stored sample, we don't have any right to use that sample.
Suppose, sir, those donors are not reachable now if you are doing retrospectively. So what should be the next thing which we can do?
I don't think we should. I don't think we should.
I would like to say, when you go for retrospective work on any samples, I think there is one way out, that is the ethical committee. You can present it before the ethical committee that we have these samples of 5 years archived HIV positive samples. We would like to do some work on it. And if the ethical committee allows, I think you can do it, because, when you go it for publication, they will ask whether you have an ethical clearance for the same. So it can be done with the permission of a waiver from the ethical committee. We have tried this, and once the ethical committee gives a waiver, it becomes usable. You can give those samples and publish those results. For prospective studies, there and then you have to take a consent, and blanket consent is not allowed, I think, as per the rules.
Yes.
And if you look into the ICMR codes, there are certain situations very clearly defines which are the situations where you can proceed without a consent also. So it would need a much more detailed thing, but there are situations where you can just collect data, just preliminary, suppose demography or things like that. So there are some situations where you can, but then there are some where you absolutely need, as Dr. Somnath said, a separate consent form, which tells what is the title and what is it that you're going to do. So it's like you need to know all the details.
Okay, Dr. Vijay, you have anything to add to the
Yeah,
conversation?
so I completely agree with Somnath's argument. So because now in recent year we are seeing that ethics issue, because of general awareness, information is available through internet. So it becomes really difficult to get waiver for whatever stored samples are there for whatever purpose you do. You hardly get that ethical waiver. You have to go with informed consent only. It's not permitting at all whatever you present. That's
Okay, so
our institute.
yeah. So I would agree with Dr. Meenu, ma'am. If the ethical committee gives you a waiver, they will not give you a waiver if it's something which needs to be taken permission from the donor. They will give permission for some things which may be done without donor permission. That's my view, but okay, I would go. There are varied opinions among the panelists, so I would say we should go with what ethical committee of any institute will allow. Whether with waiver or with donor consent, then we will have to take donor consent. So I'll move on to the next question. This was regarding consent. Now, regarding the incentivization of blood donors. Most of us are trying to convert our replacement donors to voluntary donors or recruit more voluntary donors to increase the safety of transfusions. However, there is a very thin line between incentivization and giving undue incentives to the donors. So I would like to ask Geeta ma'am, what are the different types of incentives, like whether physical, professional? So is it okay to incentivize these blood donors?
Okay, so it would depend on the definition that a particular institute is giving to the incentive. So if it's a monetary thing, then it's a big no, as everybody knows. You cannot have a monetary incentive at all, ever. At the same time, if it is a blood donation camp and people are giving small lapel pins or so those kind of things are motivating. They are not given to attract people who would otherwise be rejected, and then just because of this they'll come. So it just depends on a very small thing where you are just respecting the person's altruistic activity is okay. Absolutely, professional donors are banned, that everybody would know. So it's okay to give small little gifts. However, attracting donors based on your gift and the quality of gift, as some people are, it is heard oftentimes that people would be attracting donors by saying that you'll get this kind of a, not exactly money, but something very expensive. That kind of thing is to be avoided, definitely.
Okay, ma'am, but is there a line between expensive and non-expensive?
It cannot be given a very definite line, but definitely if somebody is donating blood so that he gets that gift is not to be encouraged. Whereas if after donating blood, if you are giving it to him as a motivation sake, it is acceptable. However,
okay,
not very expensive ones. Yes.
More often, ma'am, we also see one more thing, that when we go for a camp in such as a religious society or an office, people are donating because their boss has told them to donate, or the religious sect has actually told them to donate. So
yes.
Is it a good practice, or how do we actually not encourage this kind of practices?
Definitely, from experience, everybody will realize that whenever we end up in these situations, or even when there is a camp in a factory or an office, we do find that there are some donors like this. And in the beginning, when we were somehow going to some of the religious camps or this factory and all, when we found the reactivity rate, the TTI positivity, after that, by experience only, we decided to stop going to any of these camps. So this was my experience. I'm sure all the others would have the same experience. And I even did a study where I compared various this kind of groups also among voluntary donations, like for example the Rotary and Lions clubs versus the religious versus different groups, and I found it was striking results were found. When people are forced to donate, they will definitely be doing it out of worry for their job, mostly for their job or something, and you find a lot of reactives there. So it's definitely a practice that is not to be encouraged.
Okay, so is there any other view from other panelists?
There are other incentives like a day off from work, which many professionals get. And I think that kind of incentive can be allowed. there is a lot of discussion on the incentives often, and somebody said that they can get students get these co-curricular marks. There's a gender bias. Females usually are not able to donate due to hemoglobin and other health issues. So this creates a bias. So you have to be very careful when you're incentivizing these things. They
So,
sometimes.
Ma'am, this extra marks also should not be counted as undue incentive, because
the female gender.
No, ma'am, you are actually encouraging someone that you will get 5 marks extra. That is not actual motivation, but that is because they want those marks. Is it correct to do that, ma'am?
I don't think, because that's what I'm saying. There's a gender divide. If you've been to camps, most of the girls are out, and only the guys get the extracurricular marks.
Dr. Minu,
There's a problem.
Apart from the gender gap, I mean, in my medical college, it was once decided, where I was working prior to here. Marks. Although never reached a conclusion, we just kept the discussion. But we found that when the students heard, a lot of students, they were sometimes leaving their classes and coming, and they said, we want to donate. And when we asked them, is it for marks? Because I told them a disclaimer that I am not sure whether you will get marks. So then they would disappear. And in one of a very good paper I read last year in Vox, and there they said it was very interesting, the definition of altruism. They said even when a person is donating for no special purpose, and many people would say, no, we donate because we're very good. So even this statement was said that it is not true altruism, because he has a purpose that he wants to feel good. So, altruism is, here there is no altruism if the marks things are there. So ultimately, when I found that because of the confusion, students started coming in, I asked them not to come. I asked the institute not to bring that rule into action.
Yes, there is it's either overt or covert sense of recognition to the self or to the community. That is always there. When you're going for camps, you always feel that. There has to be some recognition.
Should be okay. Ma'am, that should be okay, but I don't feel marks or any other those kind of incentives are good, because we will not get good donors, or we will not get regular donors, if I am correct.
Yes.
So if there is nothing to be added from other panelists, I'll move on to the next question.
For example, one more thing is, sometimes people give a 1 day off. So people, just for getting that 1 day off, they will simply go to a blood bank, force us to, take, we find there are some offices where they give them 1 day off. So they will force us to accept their blood so that they can enjoy that 1 day off. And sometimes if we are deferring for some reason, so they are quite sad because they wanted that day off after donating blood. So that was another thing where we thought it was not very altruistic.
Okay, ma'am, but in my experience, I have seen that people don't take that off. At least in our institute, Government of India gives that 1 day off on the day of donation. But yes, ma'am, but I have never seen anyone taking that day off. So most of the voluntary donors don't want that day off, ma'am. I think it's okay to give a day off, but true voluntary donors never take that day off. So let us now move on to the next question. After this incentivization, let us talk about the post-donation care, especially the traumatic injury part, as was touched upon in the last discussion also. Regarding the regarding the delayed adverse event, how responsible are the blood banks or the people who are working in blood banks? What is the extent of responsibility of blood centers? If anything is to happen to the blood donor outside the blood center as well as inside the blood center, what is the extent of responsibility?
I think if you want to have a robust voluntary donation program, the blood banks have to be seen as a responsible body, and they have to take responsibility for care of the donor in anything which is in temporal relationship with the blood donation, or has been proven to be caused directly or indirectly by the blood donation. And this becomes a problem for centers like yours and mine, which are working in hospitals. If a donor has a reaction, we can have code blue, we can take them straight to the emergency. But for standalone blood banks, this sometimes becomes a serious issue. And again, the donor goes back home, and then he has some issues. 99.99% of the donors are going to have a bruise or a hematoma. And this can easily be dealt with on phone, that you have this and you can take this kind of care for this. So that covers it. But I think in the future, looking at the current scenario of awareness among the blood donors, I think it would be a good idea for blood banks to take some kind of group insurance, an insurance for the blood donors, because we are definitely responsible. I think it is a responsibility. If you are taking donors, they go back, they have a delayed reaction. I think the blood donors should be counseled, should be told that they can get this kind of treatment, and if they are not able to, they should come back to this.
Oh, Dr. Somnath, do you have any comment on this?
He called me for something.
Yes, I'm in one panel discussion, so I'll call you back. Monday we can. Dr. Somnath, sir?
Yeah, I think Minu ma'am has perfectly told, considering the current scenario. So we have to be extra precautious. We have to take the extra precautions for the donor safety. And but sometimes I sometimes think that if the donor reactions is not related to the blood donations, like one incident happened that a donor say after donations went to the bathroom and went to the washroom and smoked, and then he fell down and then he had a very severe injury. Okay, so in this situation, so if the donor then sue us that this is because of the donation, I fell down and I had severe injury, maybe had paraplegia and whatever. So so how we can, so I think yes ma'am, I think Minu ma'am wants to say something. Yeah, go ahead. Go ahead, ma'am.
I would like to say some. Can you hear me?
Yes,
I have a very important thing to say on this. That is that there is a post-donation information. And that should be given. A pamphlet should be given to every donor. One of the lines in that is written that you should not smoke for a certain number of hours after blood donation. Can you get me, Somnath?
Yes, ma'am. Yes, that's what I am taking. What I am talking, that we have to be very cautious, and we do need to inform the donors as every precautionary and every instructions properly, that what should the donor follow and what should not the donor follow, because even yeah, can you hear me? Hello.
Yes, you're audible.
Yeah.
Yes, sir.
So that's the question, because so even if we give the instruction to the donor and say if they then deny in the court, then no, I was not given in such instruction. So
that is why I'm saying that you give a pamphlet, sign and a feedback form. The two things I think they are needed. I think AIIMS also had this issue. AIIMS also had one or two.
Yes, ma'am. So we generally ask the donor to sign before he leaves that he has been explained the post-donation instruction. So that is one thing to keep record, that he has been given. If he has signed, that means he has done the due process was followed, and after that only he has left. So that was one of the things which AIIMS is doing, that we keep the record of him telling that he has been explained about the post-donation instructions. So I think if we follow this post-donation instruction thing properly, most of the medico-legal aspects would be covered up. However, if the donor informs that he has fallen and he has some injury to his body, any place, maybe head injury or some fracture or something, so are we liable to provide some medical relief to him? Are we bound to give him some emergency care or direct him to our emergency department, especially for hospital blood banks?
I think yeah, please go ahead.
No, please, Geeta ma'am.
Okay. So what I was saying was, if we look into the bioethical principles that we have to follow Whenever there is a confusion, what I do is I think about the bioethical principles. So autonomy, beneficence, non-maleficence, and justice. So if you think about beneficence, definitely if somebody has fallen down, it is worthwhile. Sometimes because our blood bank is also on the 3rd floor. So we are almost many times worried if somebody falls down while returning or something. So once one donor did fall down, so we did take him to the emergency, and one of our persons stayed with him for some time. We got the OPD card made. So I think beneficence, we should think of them. At the same time, we just concluded to have things in writing. We should think about our benefits also, that we don't need to trouble because of any of these people or any of such practices. So I think it's good. We should be, although it's not written anywhere till what duration, where we should be taking care of them. But if they need help, if they've done an altruistic act, donated blood, we should try to help them out medically as far as possible.
Dr. Vijay.
I totally agree with Dr. Geeta that we should help where we can, but there has to be a limit. And that is why I was talking earlier that in the future, with donor awareness increasing, we should think of some kind of insurance for blood donors, that if something happens, the blood bank does not become liable to pay for everything, especially when they are standalone blood banks and they do not have those facilities. It becomes very difficult to bear the expenses of all kind of treatment, especially if there's an extensive fall, head injury, or things like that. So because it is a very low prevalence, I think it is very easy to get insurance, because if this kind of things happen very rarely.
It can be a big.
So it might be worthwhile to take an insurance.
Remember, there has to be a time period, whether 24 hours after donation, or I think some time limit should be there for such things, right, ma'am?
Could be defined.
Could be defined. Could be defined. Could be defined.
So,
yes.
Our question should be not like whether we are liable or not, how we are going to approach that. That should be like Meenu ma'am is saying, that we should have some insurance. So ethically we are liable. Even donor was coming to donate blood, you have called that, okay, we need this O negative blood, and in between if he met some road traffic accident, then also ethically whatever we can do as a person, as a human. And for Somnath sir, I have just one counter, that if we have given instruction also, despite that if he is following, so then also it doesn't wash off our responsibility. It's like a patient, if he skips some of the instruction and he becomes sick, then also we don't say that don't come to us again. We have to manage that. Whatever had happened, that's fine, but we may take some preventive action, so it should not happen in to the next donor or something like that.
No, Vijay, I was not talking about our responsibility. Definitely, that's responsibilities. Definitely, we have to take care of the patients. We need to give the emergency care, whatever. But the thing is happened if it goes worse situations, like if it goes to court, and then all these issues are coming up. So I'm talking about those.
Court, it would be little difficult, because like Dr. Haim is saying that they ask for each donor to sign. So in court, donors also can say that I was not aware, I was just asked to sign something and I signed. So that becomes very difficult situation. So I think that one good advocate only can help in that scenario.
No, but still documentation should be maintained.
Yeah, so SOP we have followed, that only our safeguard.
When you have done this, the liability will definitely decrease. Liability.
Yes.
Yes, ma'am, but ethically we are bound to give care to the donor if anything.
If you have informed, you have got it signed. If you have explained there is no smoking, that this should not be done, the liability decreases. This does not mean that you will not care for him, but your liability decreases.
Yes.
Yes, ma'am.
You will not be held responsible for negligence.
Yes, ma'am.
Yes. Is the point.
Yes, ma'am. So there are some things which we need to do to prevent us from medico-legal problems, but ethically we are bound to the donor. We have to give care to the donor if he calls, and that also will help in medico-legal problems. If the donor is informed, and if we say that yes, we will provide you care or we'll guide you to some medical care, then that also is that we don't intend to create harm to the donor, and that will help us in long run. Coming to my last issue. that deals with donor reentry after the TTI testing. So it's a controversial topic, I know, but we don't have any, we face this in everyday donor post-donation counseling. So let me give us a scenario that the donor was initially seroreactive in our screening, but he tested seronegative in the repeat testing. So whether we should inform the donor or not, and if informed, then what should we advise, and how do we re-enter such donors? A number of voluntary donors actually lined up in this scenario. So whether to take those donors back into the pool, or whether to defer those donors permanently. So what is the opinion of the panel?
I have a very strong opinion on this. My first thing is about the ICTCs or the referral centers. You know, when a donation unit is seroreactive, once you discard it, it becomes our duty. We are not bound to 2 or 3 tests. It becomes our duty to inform that it was seroreactive. You are not positive, but you have to get diagnosed. We send them to ICTC. Just one scenario. The ICTC puts an even lower quality test on that particular sample. So the first thing is, if it is going to be a referral center, it has to be better than the screening center. If we are using ELISA and CLIA and they use a spot test at ICTC, it creates a big problem. Okay. The other thing is, you have to tell them that they have to go to get it diagnosed. Now they are diagnosed as negative, but they are coming seroreactive. As long as they are coming seroreactive, they will not be taken, even if they are not. We know that they do not have the disease, because according to our rules, anything which is seroreactive cannot be used.
But ma'am, I'm talking about the scenario. Generally, when we do initial screening, if it comes seroreactive, then we repeat it in duplicate again. So suppose the duplicate test comes negative. Initial test is reactive, but the duplicate test is negative. So what to do in those scenarios? It ideally it will tell us that
the question is.
Ma'am, I would come to the second question later. This is initially. Yes, ma'am.
This is the first question I'm answering. Why do you put 2 tests in repeat? The blood bank is not and does not have to do it. We just have to do a screening test. So if you're
Ma'am, just to rule out some
you're trying to diagnose it. That is what you're doing.
Ma'am, just to rule out some technical issues, it may be technically the test has been compromised, or there may be some sample related issues. So we generally take a sample from the collected plasma unit and repeat it. And we do it mostly for the low signal cutoff values, where the signal cutoff is towards the suppose we have a 1 of signal cutoff.
So that's where I am saying that.
Yes, ma'am. I think Dr. Vijay has something to contribute, ma'am. Yeah, let us see what is it.
So I strongly feel that it should be repeated for donor notification purpose. It's not the clinical use of blood. So when we are notifying the donor, if we know that are we dealing with false positive, are we dealing with true positive, it helps me, it gives me that confidence that, okay, to what certain extent I have to counsel that. When I know that it is false positive, I would counsel in different way than when I know that this is the truly positive. That is my personal experience. But for donor re-entry, I feel that India, because we have so much of heterogeneity of testing platform, there is no standardization uniform within a city itself, leave about across country. So we are still not prepared to think about for donor re-entry. Maybe as a pilot project can be taken up at Premier Institute, and the longitudinal follow-up of the donors, and then we can have some data and think of, because yes, Somnath sir.
Yes, sir.
I think Vijay and Minu ma'am are absolutely right from their perspective, because from the blood bank perspective, when the unit comes reactive, we don't have to do further tests. We have to discard it, right? But from the donor notification perspective, we need to be sure that whether it's really, because our tests are highly sensitive tests. So we just wanted to know really the donor is having some real infections or maybe it's false positive, but whatever, we have to notify the donor. But as far as re-entry is concerned, we don't have in our country so far don't have any kind of policy of re-entering the donor, even with the donor being non-reactive after a repeat test or confirmatory test. So I think now it's a time to develop a kind of a uniform protocol or guideline like just US or other countries they have, where they can re-enter the donor with their uniform, with the performance of the uniform assay, like they have an uniform protocol, like they have for say HIV positive or reactive donor, they call upon the donor after say 8 weeks and they do with ID-NAT test and with a particular FDA approved clear test. And if both the tests are non-reactive, then only they re-enter the donor. So these kind of protocols or guidelines, I think now it's time to develop for our country also. Because as today in the first sessions and the second session, we have already seen that the impact, the emotional impact of the donor being deferred, it's a huge, and it's a negatively impacting the donor mentality and donor psychology. So keeping those things in our mind, I think now it's a time to develop a standard protocol or guideline with that standardized assay, which will be followed all over the country. And with that, following that particular assay and particular protocol, we can re-enter the donor.
Yeah, even
this is my perspective.
Yes, Dr. Somnath, even I agree. It is high time we did that, and all institutes that, I mean, if even a few institutes have a good donor number and they can call back their donors, even a few of them, and go ahead with this. Unless this is done, it will be really, all of us would have experiences where we declared somebody as HCV positive or HIV, and we called them for counseling, and later it turned out to be negative. Like Dr. Meenu said, the ICTC, the tests that they are doing are inferior to ours. So we really need good policies for handling all these kind of situations that create confusions when we are handling these reactive donors.
So to conclude, if it is positive, we have to discard. That's what we also follow.
Yes.
However, we repeat it to see whether it is false positive or false negative. If it is repeat positive, then we would actually counsel the donor in different way, and if it is negative in repeat testing, we'd counsel the donor in another way. However, then re-entry is still a question mark in our country, where there are no clear-cut guidelines, and there is a need to develop those guidelines. So another aspect of this is another issue in the TTI testing is again that nowadays we have curative treatment for HCV. So for that, most of the donors, we are actually receiving some of the donors who are HCV antibodies are positive, but they are NAT negative. Now they say they have received curative treatment. They have been cured of HCV. So I know there are no guidelines, but I just wanted to know the opinion of the panel. What is your opinion? Whether those donors can be included, or is there some way we could assess them that they can be included in it because they want to donate?
Yeah, so till the time that we have like this kind of detailed studies that we're talking about and regulations regarding this, I would suggest that it is safe to defer those donors.
Okay.
Yes, ma'am, I completely
agree. That is what I would do.
I also completely agree, because as so far we don't have any kind of guideline.
I have one thing to say. When you talk of HCV, so Vasovegal has come as a magic drug, but now we are seeing a lot of breakthrough infections again in liver patients. So we don't have long-term data on the recrudescence of these kind of infections, HCV. So even if they want to enter in, we are getting them continuously non-reactive. We have to think. We don't have long-term data on this. Yes. We can't put the patient at risk.
So it's advisable to defer. Yeah.
Even one more thing, one more
Yes.
important aspect is the occult HCV. Even the NAT, it may be NAT negative, but we don't know the patient is really harboring the infections or the disease, I mean the virus, because unless we do the liver biopsy or for the mononuclear cells, we won't be able to get. So occult HCV is another important issue. So we have to, I think we need to let them understand that these are the situations that this may happen, even if you are being called that you are disease free, but still we are not sure. So, and Minu ma'am already told that, yeah, the breakthrough infections are another issues.
Yes, sir. Because our epidemiology is quite different. For most of infections, we are either high prevalence or medium prevalence. So the chances of the low level of infections are quite high if we compare with the countries where donor re-entry is allowed. So my opinion is still that we have to strengthen first our TTI testing throughout the country, and then we can like simultaneously we can working to have some policy at national level where we can start following donors for good time duration, maybe 5 years, 10 years, and have that data for our Indian population, how we behave. And we can.
Okay, so I think the panel is unanimous in this, that in such scenario, we are not supposed to take, even we should not entertain such donors if they disclose it in first instance. So thank you very much. It was a very nice panel discussion. And now I would ask if there are any other faculty members who have any comments to make. Otherwise, we can end this panel discussion.
Thank you, Dr. Haim, Dr. Gopal, and the entire organizing team.
Yes, yes.
Thank you, everybody. And it was very interesting interacting with you.
Thank you, ma'am. Thank you, everyone.
Thank you, Dr. Haim, Dr. Gopal, and your full organizing team for this highlighting this particular donor aspects and donor topic, which is now I think this unmet need of our country to look at the donor safety perspective and all these issues related to the donor. Thank you very much. Thank you for giving me the opportunity.
Thank you, Dr. Haim, organizing team.
Thank you. So I'll now hand over to my team to continue this program. Thank you very much.
Thank you all for the very interactive and informative session. Thank you all for the very interactive and informative session. Now I humbly request Dr. Rahul Chaurasia, sir, Associate Professor of our department, to declare the winners of the video session and to propose a vote of thanks.
Thank you, Dr. Aparna. Before I start with the name announcement for the winners of the video submissions and my vote of thanks, I would like to make an announcement regarding another ISBT supported virtual event, which will be held by the Department of Transfusion Medicine and Hematology, NIMHANS, Bengaluru. The topic will be therapeutic apheresis, current practices and advancement. And this CME will be held on 15th of July, 2022. For further details, you can contact Dr. Vijay Kumawat, who is the Associate Professor in the Department of Transfusion Medicine and Hematology at NIMHANS. On behalf of the organizing team, I would like to express my gratitude. We would like to thank the chairpersons for wonderfully moderating the sessions. We would like to thank the speakers also and the panelists for such amazing sessions, giving all of us a better insight of the practices of blood donor management. And I hope all of us are deeply benefited by their vast experience and knowledge about the subject. We would also like to thank all the delegates for their enthusiasm and active participation, especially in the form of video submissions and queries or comments during the discussion. We would also like to thank the International Society for Blood Transfusion for their kind support and for bearing with us as the CME was postponed for 2 occasions. We would also like to thank Team Mac Corporation, our live partner, for their impressive support towards making this virtual event as indulging and interactive as a physical event. And lastly, I want to thank all the members of the organizing team and the SET facility for their untiring efforts and support towards organizing this CME. Well, it is not the end of the world, and we will continue to seek your continuous support for similar programs in the future. Now it's time for the winners of the video submissions. This time, apart from the conventional practices of abstract submission, we requested for video clips from various areas of the blood donation area, which included the blood donor screening, donor phlebotomy, post-donation care, donor hemovigilance, apheresis, and quality control. And we received a total of 41 entries from the participants, and we were impressed by the enthusiasm and the innovation by the participants. Now, I would like to announce the winners. Actually, we initially had to give one from each section, but seeing the enthusiasm of the participants, we have decided to go for at least 10 winners for the video submissions. The first winner is Dr. Veenu Rajendran, whose video was on video demonstration of daily QC of the blood collection monitor. Then the second award goes to Dr. Prateek Srivastav with a video on estimation of hemoglobin levels in blood donors. Then third, Dr. Ruchika Bhartiya, preparation and hemoglobin estimation, preparation and QC of copper sulfate solution for hemoglobin estimation. The fourth award goes to installation of Dr. Akshi Bhardwaj for installation of Amicus single needle platelet pheresis kit. Then Dr. Cherry Gupta for the presentation management of vasovagal reaction, adverse donor reaction. Then Dr. Spruha Dholakia, platelet pheresis procedure at Live Blood Center. Then Dr. Pedinti Tejaswani, how to perform isometric exercises during blood donation. Then Dr. Angel Sam, estimation for estimation of hemoglobin in blood donors using HemoQ HV301 system. Then Dr. Yashasvi Dhiman, for presentation for management of mild vasovagal reaction grade 1 in whole blood donors. And lastly, Dr. Mohammad Shihab VK for the video clip on phlebotomy site preparation. The list of the winners will be displayed on the website, and it is requested that all the winners should send their mailing address to the secretariat so that their gift could be mailed to them. Thank you. Thank you for all. And congratulations to the winners.
Thank you all. We can end the session, please. Thank you.